Great. Welcome, everybody. This is the National Care Coordination Academy. We're so happy to have you with us today. This is our final meeting. I will try to hold my emotions to the end, but it's been an amazing 2 years with you all, and we're so grateful to have you all together with us today. We have a really excellent day planned for you. I'll now pass the floor over to Meg to do a few words of welcome.
Thank you, Heather. I appreciate that. Welcome all to the final meeting of the National Care Coordination Academy, which was a partnership between Boston Children's Hospital and the Collaborative Improvement and Innovation Network for Children with Medical Complexity, or CMC COIN project. On behalf of the leadership team at Boston University for the CMC COIN, I want to thank all of the teams for the work that you did in moving care coordination measurement forward, in helping to identify and elevate value in the context of care coordination, and especially for everything that you did in developing camaraderie and connection and communication and relationship with one another under some very difficult circumstances. We are very much aware that this work happened in the context of a worldwide pandemic, and the fact that you all had such wonderful outcomes associated with your time and energy and effort, and did that under very difficult circumstances, is just incredibly impressive to us. So thank you very much to the teams for your work. Thank you to Rich and Heather and Jeff and Erica for keeping us on track, for being our guiding stars in the work that we did together. It was a true pleasure and an honor working with you all, learning from and with you. And thank you also to our partners at HRSA for their support, for their flexibility, for their creative thinking, and their really innovative thought partnership in creating support for the National Care Coordination Academy and all the work that you all have done. Without them, this would not have been possible. So we tip our hat and thank them, especially our project officer, Anna Maria Padlin. I'm gonna stop talking now at the risk of becoming emotional myself, and I'm gonna turn the floor over to Rich Antonelli. Thank you.
Thank you, Meg.
What a profoundly important day this is. I will keep my opening remarks brief. You'll be hearing comments from me throughout today. But I would actually like to really acknowledge what you, the teams, have done under extraordinary circumstances to demonstrate how important care coordination is to achieve equity, health, and social justice. And what does it take to implement and sustain? And today, these slides, you are going to be spending most of the time actually speaking. So I'm so proud, I'm humbled and honored to have been a part of this process with you. I want to say a word of thanks to HRSA, Maternal and Child Health Bureau, every member of the team. Thank you for your vision. I know when the CMC COIN first launched, the Care Coordination Academy wasn't part of it, but then that vision, that spark occurred. Meg reached out, and Meg, you've been an invaluable, inspiring partner. Thank you so much for that. Anna Maria Padlin, Treeby, Letitia Manning, who is here today, Michael Warren, Marie Mann, who has retired but was also part of the formulation of this. Thank you for your confidence. Thank you for your trust. Thank you for your energy. I want to thank the teams at Boston Children's Hospital as well. Heather, Pamela, just talk about a true national treasure with the way she's grown professionally. You've been an amazing colleague. Erica Norkus, you've been coordinating for this, literally adding it on to everything else you do, and you've been a wonderful, wonderful colleague. My BU colleagues, Beth Lynn, Virgo Houlihan, Jessica Flaherty, and Meg that I've acknowledged already. Renee Turchi from St. Christopher's, always a guiding light for me, and a wonderful, wonderful, brilliant partner. And to Jeff Schiff, who's literally on the other side of the world on a family visit, but making time for this. Thank you for making this possible. So I just wanted to start with the acknowledgement, really looking forward to having you share what you've done today. and having our guest faculty here. So I'll hand it back over to you, Heather.
Thank you so much, Rich. All right, just a couple of our usual housekeeping slides. I'm sure you all have these memorized by now, but just letting you know, this meeting is being recorded. We actually do not have team breakouts today, but just as a reminder, the breakout rooms were not recorded. We encourage you to try to not use speakerphone or put us on hold, and we would like to have you muted during the presentations, but then you're welcome to unmute when we get into questions and comments. Please rename yourself to include your state team name first. Just helps us identify which team you're coming from. So if you can put your state abbreviation in the beginning, followed by your name, that would be very helpful. The chat will be moderated throughout today. Please put questions and comments into the chat. And if you're using a phone and computer, please try to link them together so we just see you as one participant. This just goes over how to rename yourself. You'll find yourself in the participant list. You want to right click on your name, hit rename, and then put your state abbreviation first, followed by your name. Today's session is eligible for continuing education credits for the following professions: RNs, NPs, MDs, PAs, and social workers. What you need to do to be able to obtain your certificate is you will sign the attendance Google Doc. Erica will share the link in the chat a couple times today. She'll send it out now. We'll send it again midway through the day and then again at the end of the day. And I will also email it out later. If your facility does not allow you to use Google Doc, please just email me and I'm happy to add you to the attendance. We'll ask that you complete the evaluation at the end of today's session. And then in about 2 to 3 weeks, you'll get a additional survey email from Boston Children's CME department for you to fill out, and we'll also include instructions for how to access your certificate. If you have any questions about this or any issues, just send me an email and I'm happy to help. Rich, I'm going to hand things back over to you to go through our great agenda for the day.
Thank you, everyone. So we're thrilled, and actually part of the reason why we moved the May session to mid-June is because of the release of the Blueprint for Change. Letitia Manning from the Maternal Child Health Bureau will be discussing this in a shared discussion with Jeff Schiff. I'm not going to steal any of their thunder, but we're going to be opening with that. Thank you. Thank you, HRSA and Maternal Child Health Bureau, for giving us the guideposts for going forward as we seek and prove what sustainable care coordination and equitable outcomes will look like. Then we have a brief summary of the Care Coordination Academy evaluation with the team sharing just some of the highlights that we could distill into a 15-minute discussion. There will be a more robust report that will be gathered, and Jeff will give you a little bit of the insight of the big picture of that, but we're thrilled to share what you guys have reported about your experience. Then following a very brief break, each of you will be on the podium. Heather will give you the logistics for that, but we've asked everybody to reflect on what worked, what some of the challenges are, so that we could think collectively of, even with the sunset of the Care Coordination Academy, what's next? And then finally, we will wrap it up. We'll try to have tissue boxes virtually available for those of you, and if not, you should run and get one at the break. The next slide. The land on which I and many of my colleagues here at Boston Children's Hospital work is located on traditional, contemporary, and unceded territories of several Indigenous nations, including the Massachusetts, the Mohican, the Nauset, Nipmuc, Pennacook, Pocumtuck, Wabanaki, and the Wampanoag. These lands were taken from the Indigenous people, creating a legacy of trauma that persists to this day. Next slide.
Thank you, Rich. I'm just going to let you know today's learning objectives. So after the session, we hope you will be able to understand key elements of the Maternal and Child Health Bureau Blueprint for Change, a national framework for a system of services for children and youth with special healthcare needs. We're so grateful to have Letitia Manning from HRSA be here to present on that. And as well as you will have identified next steps to be taken to continue to advance your team's work after the Care Coordination Academy. Jeff, I'm going to hand things over to you to introduce Letitia. Jeff, are you there?
I said nice things that I'll repeat.
All right, take two.
Hi, everybody. It's a pleasure to introduce Letitia. Letitia is Lieutenant Commander in the U.S. Public Health Service and in the Maternal Child Health Bureau. She's in the Division of Services for Children with Special Healthcare Needs. Letitia did double duty besides being a mom of some great kids who we got to see every once in a while during the pandemic when she was often or at times deployed, and then coming back to check in and be part of this big effort to create this blueprint. And as I'll talk about a little bit later, Letitia and Meg and I are three of a group of authors on the paper on financing of services. And what I said on mute was that if you need a partner to build consensus and get things done, you should all work with Letitia. So Letitia, my pleasure to introduce you and take it away.
Thank you, Jeff. That was such a nice little introduction. Thank you for that. Well, so good afternoon. Jeff has already given me a wonderful introduction. And I just want to say thank you to the Care Coordination Academy, to the CMC COIN for allowing me to join you all today. I had the opportunity to participate in the COIN meeting last week. I was able to attend virtually some sessions, and I'm just so impressed with the tremendous work that you all have been doing, have done, what you all will be doing in the future. So it was really great to participate in that. So we at MCHB are super excited about the release of a blueprint for change. It was released on June 1st. And it was released in a supplement in pediatrics along with other articles. I'm sure many of you have already received numerous emails, tweets, or other communication about the blueprint. And I hope you're not annoyed, but I hope you can see that we are really, really excited about it. And we're grateful for all of our partners that have amplified its release. So today I'm gonna just give a pretty brief overview of the blueprint and the articles. And then I believe we'll have more discussion when Jeff shares some specifics about the financing article. Next slide, please. So before we begin with the blueprint, I just want to briefly mention the MCHB strategic plan. The mission is to improve the health and well-being of America's mothers, children, and families. And the vision is an America where all mothers, children, and families thrive and reach their full potential. It was created with input from many, many, many people. And the goal, it's as far as the guiding the number of years that we hope that this strategic plan will guide our work, we're looking at 10 to 15 years as opposed to like a shorter time frame, partially because the government, we plan way in advance. So we're hoping that this strategic plan will guide our work for 10 to 15 years. There are 4 focus areas on our strategic plan around access, equity, workforce capacity, and impact. And we believe that these are the pillars to achieve our vision of an America where all mothers, children, and families are thriving and reach their full potential. The blueprint for change is a part of MCHB's strategic plan, and you may see similar themes in both. So I encourage you to take a look at the MCHB strategic plan if you have not. Next slide. So as a reminder, these are the 6 indicators of a well-functioning system. These core indicators were developed in the early 2000s. So it's been around, for 20 years, 20 plus years. But currently families, based on recent national survey of health, recent data from the National Survey of Children's Health, it tells us that the current system of services is not working well for SHIN populations. So nearly 14 million or 1 in 5 children have a special healthcare need, yet 85% of CYHCNs still do not receive care in a well-functioning system. And I know, as you all did so much of your work during COVID, and many of the recent disasters and social economic unrest, you know that these things definitely disproportionately impact SHIN populations. So I just want to emphasize before I start talking about the blueprint that these 6 core indicators, this framework still remains with the blueprint. However, the blueprint adds the lens of these 4 interdependent areas of health equity, quality of life and well-being, access to services, and financing of services in order to further strengthen this system of care. And it's really based on what families of SHIN told us was important to them. So once again, I'm just reiterating 6 core outcomes, 6 core indicators. It is not going away. Next slide, please. So the development of the Blueprint for Change started back in the fall of 2019. MCHB did not create this blueprint in a vacuum. We collaborated with SHIN and their families, healthcare professionals, public health leaders, researchers, and more. Many of you all provided feedback and comments somewhere in the process. And we're grateful for all that you have done thus far. We had a SHIN summit and we got a lot of feedback from that. And we also had a steering committee that guided much of this work. The development of the blueprint began pre-COVID and it evolved during COVID. So if you happen to have seen the request for information, which had a draft blueprint back in, I guess it was released in 2020, it has changed some, partially because of the experience that we had during COVID and just, you know, we definitely received the comments and we incorporated them in the creation of this Blueprint for Change. Next slide, please. So the goal of the blueprint is to align with the 6 core outcomes framework. And as I mentioned previously, it provides a new lens of equity, access, and quality of life. The goal is to strengthen the system of care. And it has developed, it has actionable goals and objectives at all 3 levels, the community level, the state level, and the federal level. Next slide, please. So what's new in the blueprint? There are some new things in the blueprint. I know when we do a lot of this work and we're ingrained in a lot of this work, some of the things seem, you know, it seems kind of repetitive, like, oh, we know that, or oh, we've heard this before somewhere. But you know, they're what we believe are kind of some new concepts and more of a focus on certain concepts. So there's a call for healthcare systems to measure outcomes that are meaningful to children and families. And I know that you all in the Care Coordination Academy have worked a lot on measurements. And we think that is a great thing. And we think and hope that that will continue to push the field forward. I just want to emphasize that in the blueprint, there's really a focus on measuring what is important to families, measuring what is important to SHIN, and measuring what's important to families. There was also a call to address upstream and downstream factors that prevent SHIN from a fair and just opportunity to be healthy. There was a call to design a system that is built around the needs of children and families and not just, you know, treatment protocols and diagnosing children. And there's an understanding that if we improve the system of care for SHIN, then all children will benefit. It is not just about SHIN, it's about all children. And the last thing I'm going to mention about what's new in the blueprint is that there are 4 interdependent focus areas that center around the issues families consider most important to strengthen the system of care. And I'm going to go into more in depth about those 4 things. Next slide. So we went back and forth on this image. This image looks very simplistic, but we really had a lot of in-depth conversation about it. So as you can see, there are 4 key areas: quality of life and well-being, access to services, financing of services, and health equity. So initially, there were some images that were drafted that kind of had standalone focus areas, but it was really important to all those that contribute to the development of the supplement and the blueprint that these be interconnected, that they aren't standalone pieces. So in order to move the field forward at the community, state, and federal areas, we felt like these 4 areas needed to be interconnected. They rely on each other, they depend on each other. And if you read the articles within the supplement, you will see mention of different things mentioned in other articles because we know that these areas are so interdependent. Next slide. Okay. So I just want to, before I talk more specifically about the articles, I did want to just give you an overview of what's in the supplement. So the first article is a blueprint for change, which provides rationale, guiding assumptions, principles, and strategies to achieve the overall vision. And then the next article is a profile of SHIN. It's written by some of our colleagues in the Office of Epidemiology and Research, and it describes the sizable diverse population of SHIN using the most recent national survey data from National Survey of Children's Health Data. Then we have an article written by Dr. Warren titled Progress, Persistence, and Hope. And it describes the public health role in building a well-functioning system of services for SHIN and has some great background on the history of MCHB and children and youth with special health care needs. And then finally, we have the 4 articles, which I'm going to talk about now, which cover our 4 interdependent focus areas of health equity, quality of life, access to services, and financing of services. Oh, I'm sorry, Heather, is there a health equity one there before this one?
Hang on, I have this slide and then the one that comes next is this one.
Okay, all right. Well, I will just talk a little bit about the health equity really quickly. So the health equity article, the vision is that all SHIN have a fair and just opportunity to be as healthy as possible and to thrive throughout their lives. Within that article, there's a table 2, which describes the lived experience of discrimination and health system dysfunction as told by 2 authors. So 2 parents described their experience related to health equity. And it was very powerful for me just to be able to read it. I mean, we all hear stories, we may have experienced things ourselves, but to see it written in that format was very meaningful for me, and I hope it will be for you also. There's also some data in that particular article that describes SHIN as being more likely to live in poverty than non-SHIN, and that white SHIN populations and SHIN and more financially resourced families are more likely to receive care in a well-functioning system. And the approach to address some of these issues, some of these upstream factors, is to address the upstream and downstream factors that inhibit SHIN from a fair and just opportunity to be healthy. And then for the family and child well-being and quality of life, is that next slide, Heather, or previous one?
Let's see, I'm sorry if they got mixed up at all.
Oh, that's okay. If you just go back a little bit, let's see. Right here.
Here's that
Okay.
one, there you go.
Yes, thank you so much. So the vision is that the service, for the service system to prioritize quality of life, well-being, and support flourishing for SHIN and their families. The data states that SHIN experience disparities in quality of life and well-being using indicators like the number of school absences, child's ability to make friends, and living in a supportive neighborhood. And there was a lot of focus in this paper around measuring outcomes that are meaningful to children and their families. We really need to focus on measuring what matters to families. And that was a key takeaway from that article. Next slide, please. So the access to services, the vision is that SHIN and their families have timely access to the integrated, easy to navigate, high quality healthcare and supports they need, including but not limited to physical, oral, and behavioral health providers, home and community-based supports, and care coordination throughout the life course. And sorry, my slides are just mixed up a little bit. And so we're gonna speak a little bit more about the care coordination component of this access to services, I believe, in the next couple of slides, or when Jeff comes on. And then the last article is around financing of services. And the vision is that healthcare and other related services are accessible, affordable, comprehensive, and continuous, and they prioritize the well-being of Shin and their families. And the data states that only 63% of families with Shin have adequate insurance coverage. Families of Shin are more likely to report problems paying bills, reduced employment, and being in a job loss situation when they can't change jobs due to the loss of benefits. So the approach to address some of these things is that there is a need for a service system to support finance improvements to ensure access, equity, and system integration, and to ease the financial burden on families. Next slide. So there are a couple of call outs to care coordination specifically in the blueprint. And it's mentioned in the access of services paper, as well as in the financing of services paper. And really within the blueprint for financing of services, care coordination and care integration across sectors are considered to be medically necessary and adequately funded to manage varying service needs as defined by the family. So the work that you all are doing, the work that you all have been doing is extremely important in addressing some of the issues described in the blueprint, in the articles related to the blueprint, as well as how to make change. And the work, we put the blueprint out, the blueprint was just released June 1st, but you all had already started doing the work. Next slide, please. So lastly, I just wanted to give a few reflection questions, just some things for you all to think about. What can we learn from the blueprint and its applicability for care coordination? Are there similarities between the blueprint and the quadruple aim outcomes? And are there specific areas of the blueprint that can provide guidance to the field of care coordination? And that's all I have. And so I'm just going to pass it off to you, Jeff.
Thank you so much. I want to spend just a little, I want to just do my segue by saying that Letitia's right on that this is a group that's already doing a lot of the work here. And I always think when we come up with, we were asked, and I kept on saying this to myself, and I write it on the top of my notebook every time we have a meeting, aspirational and achievable. So we were asked to come up with recommendations that were aspirational and achievable. I want to just say that the team, you'll see two of us, Karen Van Landeham is at Nashby. Karen Langer is a physician lawyer who actually works in a HMO right now, but was a Medicaid medical director. And Mike Schutz was the data geek from Kentucky and is now working for the Kentucky Hospital Association. Some of us know Meg. But I just want to say that in this group, we have an accumulated life experience in those areas I talked about, but a very significant life experience for many in this group with of having a family member with special health care needs. So I just want to go over, I pulled out just for this group, I wanted to pull out a few of the recommendations in the financing of care part. And I hope that as you work in your states going forward, you take this article and some of the other ones and link the recommendations you make to policymakers in your state to the national recommendations. And that this gives momentum to say, these are already part of the national landscape. So how are we going to enact them in our own state? So I can go on to the next slide. We had recommendations and opportunities for innovation. The first one is really, I think, something that we all believe. The financing of child health should be conceptualized as a long-term investment rather than a limited time cost. I don't think there's a person on this call who doesn't believe and live that. The next one I will say is something that I'm thrilled to finally see in print. And I think what we really wrestled with was really to say, how do we provide the insurance access for kids with special health care needs And we really felt that at the end of the day, the EPSDT criteria were so significant in helping kids get what they needed that we really thought that there should be mechanisms developed for at the federal level to optionally expand Medicaid for all children and youth with special health care needs. There's already, many of you know, there already are kids who have SSI disability who can get in no matter what their income level is. But this is an opportunity to really say that it's not, even if you don't qualify for that, it's, you know, the burden on a family of finding insurance, their need to understand the healthcare system, and their goal of serving the child and their family are in those last two are enough of a burden without enough of an opportunity and challenge without having to look for insurance. So we're hoping that this gets some traction with you in your state or with us at the federal level. Next, a few other recommendations that we wanted to point out. These are recommendations to adequately fund long-term services and supports, and specifically home and community-based services. And then the next one, you can go to the next slide, is that we should adequately fund primary care, care coordination, and care integration, the essence of this academy and the essence of a lot of your work. And we really felt like we needed to call out the need to adequately fund both of these things, and I think they fit obviously very well with the 6 indicators and with the new strategic aim of MCHB as well as the blueprint. And then just a couple other things I wanted to point out that if you could just go back, I just want to say these are the recommendations as they appear in the article. So there's some that I'm skipping here, but we really wanted to make sure there was funding to test, develop, evaluate, and support the spread of models of care coordination and care integration. And that's really about investment, hopefully from MCHB and from other federal agencies. And then the last two I wanted to point out to this crowd, if you go to the next slide now, Heather, are we need to, and this gets to the issues around measurement. We need to develop accurate, reliable measures to enable effective monitoring and evaluation of system level financial innovations. And there's need for the same thing with monitoring and evaluation of other innovations, not just the financial ones, but this was the finance article. So we wanted to make sure that we didn't leave out the ability to know if value-based purchasing, alternative payment models, et cetera, are working. We don't want to rely on anecdote for those kind of things. It's so important to get that right. And then we're hoping that we align measures across federal programs so that we have common measures across programs. So these are some of the things that are going in the article on finance. The articles are, you know, all of the authors and the writing teams did a great job, and it's not something that you're going to read like a novel. I promise you it's not that good, but it is one of these things that I think it's really important to hopefully use this for momentum in your own state or area. Next slide. So I think this is the end of this. I wanted to we just have a few minutes, and Letitia said at the beginning, like, and I guess I just want to have a little conversation about what happens next here. Like I know that we're spending time in our own networks advancing the blueprint, and I know that the federal government's trying to get this out. But I think the next actions probably come both from activity at MCHB and then also activity and how people take this up and use it in their own organizations. Meg, I'm going to ask you to actually come on just to mention the thing you just put in the chat.
Sure. Jeff, thanks for the opportunity. So point number 9 here, that research organizations, federal agencies, and payers, in collaboration with families, providers, and communities, developing accurate and reliable measures. I think that that's a really important and innovative point to have made in this paper, and in part because historically, the identification of value and the identification of measures, and especially outcome measures, has been very siloed, and it has not fully integrated all of the different multidisciplinary stakeholders that are critical when you think about a well-functioning system of care for kids and youth with special healthcare needs. And so I just popped an older paper from pediatrics into the chat box that I thought might be of interest to our audience. And it is a paper written by a group of family leaders who talked about value and quality from their perspective, and really stressed this point about integrating the needs of payers, the needs of federal agencies, the needs of research organizations with families and providers and communities, and sort of bringing them all together when you think about value and quality, so that we're thinking holistically about the system, we're thinking holistically about financing that system, because in the end, we want to be thinking holistically about kids and families. Thanks.
Thanks. Letitia, anything else you want to add about the future of this work? I know that the agencies and the Bureau are really working on getting it out there. If you were to look at this 5 years from now and see success, do you have any thoughts about what that would look like?
So first of all, I want to address a comment in the chat. I believe there's a question about whether there will be some upcoming public webinar sessions on the blueprint, and the answer is yes. This is just the beginning. I think this is my second presentation. I think others are doing some presentations, and I know that Dr. Warren really supports this work, and he's going to be doing some work around it as well, some outreach work, some conversations. And we'll be working with our partners at AmChip also. So definitely more opportunities to have more dialogue. So to your question, Jeff, about like in 5 years, what would I see as success? I think the blueprint, it's provided a guiding post. And yes, there is work that's being done, but I think there is work that's being done in various sectors, right? It's very fragmented work. So what I would view as success in 5 years, and also acknowledging that a lot of this is hard work, and it's addressing things that have happened years and years and years, so it will take time to address some of these things. But if those core sectors could have conversations and to be somewhat on the same page about what's what. So we're not duplicating efforts, and we're kind of starting to push and move things forward. I would see that as a success. I mean, little by little, right?
Yeah, no, I think that's a great point, because, I don't think there's a lack of will. I think there sometimes is a lack of system integration. And this is an opportunity to call that out and to do that. And I actually feel like, presenting this to this group is like bringing coals to Newcastle, because this group has done so much of this work already. So it's really sweet to be able to come here, and also I think to tell this group that it helped inform the blueprint as it got developed, because we were developing the blueprint and the articles at the same time we were watching what work was going on. So very cool. Any other last comments about this? We're going to try to stay on schedule because we have so many teams we want to hear from. So I think Letitia, thank you for presenting, but more importantly, thank you for everything that went behind the scenes. And I hope we get to work on something complicated again together.
Yes, absolutely. And as we find out more about different presentations, I'll be sure to share with this group also. And you all feel free to push the word out, share with your colleagues and partners, and happy to to continue to have dialogue around this.
Excellent. Excellent, excellent. Okay, I think we're going to pivot. I'm doing this by myself. Heather, is that right?
Yes, yeah, thank you so much, Letitia and Jeff. You can actually keep on going, Jeff, if you want, because you take these first couple of slides, so feel free to introduce
you
this
bet.
next area.
So as we were planning this last session of the Care Coordination Academy, we wanted to talk about the blueprint because we know the timing was so important. And then we wanted to acknowledge and talk at a high level about what we got out of the impact evaluation. And it was really, I want to first of all thank all the teams for filling it out. I'm sure if you never see another survey from us, that would be okay. But the surveys have been really important for us to guide how we develop the academy, as well as to understand the impact it had. So we're going to go over in about, I think about 7 or 8 slides, what we got out of it. We haven't had as much time to read every word of it, but I guess I should say we haven't read every word of it more than once, but we've read a lot of the words of it, and it's really impressive what you've done in aggregate. So we're going to do this first, and then we're going to give every team a chance to talk. So I'm going to go on to the next slide and just say that the impact evaluation looked at progress towards developing and implementing the elements of the three-legged stool. And we put sustainability at the top of the stool, but I think we really have to rename the top of the stool sustainability for families, youth, and children, because that's where we're all going. The impact evaluation asked at the end of each section 4 standard questions on what was helpful, what was hardest to implement, what future support you want, and what tools or products you could share. And that section, I don't think we're going to get into a ton of this in as much detail as we want to, but maybe you will when you present. It's pretty cool to hear about that. I'm going to go on to the next part of the process. This is one of 3 evaluations, a family evaluation of family of your experience and impact we didn't have a chance to get or look at yet, but we're looking forward to that. And then the learning evaluation of the teachings of the NCCA is being done as well. And then the next slide. So impact, we have been living this graphic. I think we could improve it a little bit, but it's a graphic that I think really speaks to how we get programs for children and youth with special healthcare needs, for CMC, and for all children going. We have to pay attention to all 3 of the legs for it to stand. And then next, I'm going to turn this over now to Rich and Heather, who are going to take us through some of the results from you guys, and then I'll be back on, and then we'll hopefully finish up in time. Thanks.
Thank you, Jeff. I just want to reiterate what Jeff said. Thank you all so much for taking the time to complete these surveys. We really appreciate it, and we had so much fun going through all of the data. I just want to highlight some of the data that we got back regarding the model of care coordination. So what you told us, the National Care Coordination Academy participation was associated with progress in identifying patients that are in need of care coordination. We spent a lot of time on this in our beginning sessions of really trying to work on identifying those patients that really need care coordination most, and how to stratify and make sure that they're receiving the care coordination that they need. You told us that the Care Coordination Academy was associated with screening for medical risks, as well as screening for social risks, and planning with families. Planning with families was really highlighted a lot throughout this evaluation. We really appreciated seeing that, as we really wanted to stress the importance of doing all of this work with families side by side. You also told us it was associated with integration with community resources, as well as improved care plan tracking and follow-up. One of the quotes that we thought was really special, down at the bottom, you'll see, because of the National Care Coordination Academy, we are more aware of how to assess the needs of clients, which will influence future program development. So additionally, what you told us in regards to staffing for your care coordination model, the care coordination staffing model added some paraprofessionals who are not necessarily physically co-located, although some may have been virtual. And these could include community health workers, or patient educators, or patient navigators to help facilitate the care coordination and integration. So the pandemic, as we've mentioned, we put on this Care Coordination Academy through the pandemic. You all were working through the pandemic. We were able to do a lot of this together, and it wasn't easy. But one thing you told us, which I think is true with a lot of facilities, is that telehealth was really important and was able to make it so that the work could go on. And a lot of families, providers, and everyone really appreciated the opportunity to do telehealth and to continue telehealth today, despite things getting back to the new normal, I should say. So telehealth was adopted throughout the pandemic in most places to provide virtual care coordination visits as well as regular health visits. And this increased the use of telehealth for both clinical service delivery and care coordination communication. A lot of you told us it increased your work on social determinants of health, particularly screening for housing and food needs. Telehealth expanded the number of interactions with families by care team. You were able to reach a lot more families. You were able to see different things. I think specifically myself, having a lot of virtual visits with families, you were really able to be in their home with them, and see for real life what's going on. So COVID created an improved but more virtual model for teamwork that was better attended and more effective. And a quote that we saw in one of the evaluations was, ironically, communication and integration amidst the pandemic has improved, in large part due to capitalizing upon virtual platforms. I would say like this Care Coordination Academy that we were able to put on. So to just talk a little bit about measurement. So Letitia talked about it earlier, the importance of measurement for this population, and that measurement is very feasible and it's completely essential. So measurement was important for the teams in achieving their goals and gaining buy-in from system leaders. So some of the tools that we've talked about throughout the Care Coordination Academy, you all were able to put into action. I would say all, I think, but one team was able to implement PICS, which is the Pediatric Integrated Care Survey. It was well received and very appreciated. CCMT, the Care Coordination Measurement Tool, a lot of you are using that. A lot of you have already gotten great data out of it, and you were able to customize it to your population's needs. All of you use the FESAT, so the Family Engagement and System Assessment Tool. That was excellent to be able to identify your current needs with families, where things are going well, and areas that you can improve on. And as mentioned, all three of these were the main top tools that were introduced and implemented by majority of you all. So we want to just stress a focus on measurement is what is needed for sustainability. Measurement is essential, and keeping us focused on the details and value of measurement. It's not very exciting work, but it's critical to sustainability. So thank you all for all you're doing in this space. Jeff, I'll hand it back to you to go over the finance.
Great. We asked a lot of questions about finance. This was a question that we asked very specifically, and that was, do you feel your program achieved a more solid footing, more financial or operational viability because of your NCCA participation? And 10 of the team said yes, and 2 said no, or hopefully not yet. But I was very heartened by this result, because I thought that this really points to the fact that we helped maybe strengthen that leg of the stool for many of you. We have a lot to look at and break apart in this, but included fees for services, which is the most prominent way folks were getting paid at this point per member per month payments were there, and then grants were both internal and external were also there. And the money came from a lot of different places: internal organizations, Medicaid, MCOs, private insurers, and Title V. And I don't have it on here, but one of the things that I thought was really heartening is that when we asked who was most supportive in your C-suites, the chief medical officers came up first, but very close behind them were the chief financial officers. So I'm really glad to see that organizations took it upon themselves to do the level of work that's needed to get the finance people to start thinking about how to make sure we sustain programs for kids with medical complexity. Next slide, and I think this goes back to you guys.
Yes, thank you, Jeff. So as Jeff had mentioned, there was a separate family survey modeled on the FESAT, but focusing on the collaboration at the level of the National Care Coordination Academy is being conducted. Those results are coming in, and we are going through them all. And so we just wanted to stress that parent and family engagement was crucial to this team composition. We're so grateful for all of the family and parent and patient leaders and participants that were able to join us and be part of this journey with us all. We couldn't do it without you. And to just note, parent participation requires funding. This participation in these projects competes with other family demands. Participation from parents from diverse communities was more of a challenge to recruit and maintain. And then a quote that you guys had mentioned to us in your evaluations is, because of the National Care Coordination Academy, we are more aware of how to assess the needs of clients, which will influence future program development. So thank you all. Thank you to our families, parents, and patient leaders for being with us on this journey. Thank you, everyone. Rich, did you want to add anything to this?
I'll just maybe about 1 minute of commentary to sort of tie together these key messages, and then Heather, you'll set us up for the break and take us, get the teams ready. So what did we hear so far? I did a report for the Commonwealth Fund probably almost 20 years ago now, and had the privilege of interviewing the woman at the time who was one of the leads at the Agency for Healthcare Research and Quality, otherwise known as AHRQ. And she said, care coordination is the answer, but what's the question? And I think that you folks have done a great job helping to define the question and the questions. We know what it is. We know that you can implement it. We know it takes resources. We know that you can't do it without putting families conceptually at the center of what we're trying to accomplish. And while this is humble work that occurred during an unprecedented public health emergency, we need to relish the fact that, as Heather pointed out in her slide, care coordination measurement is feasible and it's essential, and it's the only way to achieve equity. So Letitia Manning, I'm thrilled to see the emphasis on equity across all those domains of care. And the only way we're going to make meaningful progress toward equity is through measurement. So I'm thrilled to hear about this. So thanks to everyone. Heather, I'll let you be the segue to the break, and then we'll bring people back.
Thank you so much. All right, everyone. So we are going to take a break until 1:05. While you're on break, the next slide I have, the Care Coordination Academy was able to present a poster at this year's AMCHIP conference. I will have it on display for you to take a look while you're on break. When we return, we will start with the team presentations. Each team will have up to 8 minutes to present. We encourage the use of the chat for questions and comments. We will try our best to address them all, but it may need to be that we wait until the end of the presentations to make sure that all teams are able to present their slides today. So if you'd like to go ahead, come back please at 1:05, and the AMCHIP poster will be on display for a little bit. Thank you, everybody. And thank you again so much, Letitia Manning, for being here. Excellent. So now we're in the most important part of the day, hearing from all of you all and your experience in the National Care Coordination Academy over the last 2 years. I know some of you may have joined just for the second year, and we're so grateful for that. The order you'll see on the screen is the order that we will present in today. Those of you that have sent me your slides, which was majority of you, I have them already queued up, ready to go. So I'll just ask that the team lead comes on when you see your initial title slide come up, and I will happily take you through your slides. Just say next slide when you'd like me to move on. Rich is going to help me moderate today and help keep us all on track. As a reminder, we are giving teams up to 8 minutes. We want to try to stay within that time frame to make sure that all teams can present. If you have questions or comments, we encourage that you put them into the chat. We will try our best to address them while the teams are on the podium, but it's possible if the teams have not finished their presentation that we will have to address comments and questions at the end. So thank you all so much. Rich, is there anything you want to start off by saying, or would you like me to jump into the first presentation?
I think just to give everybody a heads up, I will be initiating an 8-minute timer with each one. I'll maybe just do a verbal 1-minute warning. If you finish well ahead of that and there's a question in the chat, we'll try to do it in relative real time, but we want to be respectful that each of the teams has a chance to share their great work. And as Heather mentioned, if we have time at the end, we'll try to address as many of the questions and comments in the chat. And if not, those questions and comments in the chat will be curated afterwards, and we can try to connect the folks making those comments and questions with the respective teams. So with that, Heather, we're ready to go.
Thank you. All right, so our first team is from Buffalo, New York, John R. Oshie Children's Hospital. We have you here today with us.
Yes, I will be presenting.
Excellent. Hi, Erin.
Hi there.
All right, you let me know when you'd like me to move along.
Yeah, you can advance. So good afternoon, everyone. My name is Erin Girardi. I work for Oshie Children's Hospital in Buffalo, New York, and I'm presenting on behalf of Vicki Landis, the Director of Pediatric Public Health and Integrated Care at Children's Hospital. So our team goals were to develop tools, processes, and evaluation measurements to coordinate care for children and families from our specialty and our primary care clinics. Our specific aim is to improve care coordination between primary care providers, specialists, hospitals, and community agencies. You can advance to the next slide. So we originally planned to work on a NICU transition of care project, but unfortunately, we hit many roadblocks along the way due to union restrictions. So that project's on hold until contract negotiations are finalized, which won't be until August. So we had to pivot and we changed our focus to implement a more targeted care coordination in our 2 primary care clinics. We gathered population health data on our patients through Healthy Intent. We had MPH students from University of Buffalo evaluate different social determinants of health screening tools and adapt one to meet the needs of our pediatric population. And we have been using that in both of our clinics. Clinic roles, staff roles and responsibilities were evaluated and reassigned to meet the needs of the patient population. And we coordinated with CBOs to make warm handoff referrals. So one of the accomplishments we saw, particularly from meeting the SDOH needs of our patient population, was an increase in show rates. So we had pretty significant no-show rates in Q4 of last year. For example, there were 30 to 40%. And by Q1 of this year, we're down to 10 to 20% no-show rate. So we saw large improvements there. We can advance to the next slide. We created a community care network team through the support of the Academy with providers, residents, CBOs, and managed care. And we were lucky enough to receive multiple grants from foundations to help support all these efforts. So some examples include, we implemented a farm to clinic mobile market from an identified community need of food insecurity. And we also are hiring a registered clinical dietitian under that grant. We're implementing Healthy Steps. So we're hiring 2 care coordinators and 2 licensed social workers to do that work. And we're implementing psychology testing for autism and learning disabilities within primary care and developing a fast track referral system for partnering community providers to refer to us. So just for context, current wait for psychological testing within our community is 12 to 15 months. So we're really filling a huge need there. You could advance the next slide. So some of our challenges include union restrictions, like I mentioned in one of the first slides. Data is always kind of a struggle and something that we are always focusing on. How can we get more easily accessible population health data? And then patient engagement has historically been a challenge, but we went down to basics and to the foundation of really working to build trust with our patient population, with the communities we serve, so that we're able to engage with them more authentically on what their needs are. You can advance to the next slide. So next steps, we're really excited about a family and community advocacy forum starting with our primary care and outpatient clinics. So recruitment and planning is happening right now, and we're holding our first forum in August. And like I mentioned before, a need is more easily accessible population health data, but we've been working very closely with our IT team and putting money into platforms and systems to make sure we're able to pull that data out more easily. And the last slide is just our team. I mentioned Vicki, the Director of Pediatric Public Health. We have our CMO, Dr. Turkovich, on our team, and then many other doctors and managers helping out. So that is all for us.
Erin, this is Rich. That was wonderful. There's about 2.5 minutes. So if people have a comment or a question, just please unmute yourself and ask. But I'll start with a congratulations. I'm seeing several sparks of really positive work. Comments or questions for our team from Buffalo?
I just want to say, I think it's great as well. You were able to see such a drop in the no-show rate. What do you attribute that to? Were you able to set up, transportation, or what types of needs did you guys identify that you were able to help with?
Sure. So a couple of things we did. We implemented that SDOH screener that is given out to every patient or family, and we're able to link folks up specifically with transportation needs. We're also having our front desk or clerical staff call after a patient no-shows for an appointment, and they call within 24 hours and say, hey, we noticed you didn't show up. Sometimes it can be hard to show up for these appointments. What would help, or how can we help you make your appointment next time? And scripted out how to kind of draw those needs out from the patients and the families, and then address those needs in the moment. So again, if it's transportation, if they can't get time off of work or they have childcare issues, we have kind of a workflow to address all of those needs.
That's great. So it opens the door more rather than just calling to reschedule or just letting them know they missed it. That's awesome. That's really great work.
And Erin, it looks like you've really focused on access. I'm particularly excited to see about the autism spectrum enhanced access model. Even before the pandemic started, waits of a year or more were not unusual. And there are some teams that are not necessarily in this academy, but around that have actually shown enhanced access using some of the same tools, SDOH assessments and care plan formulation. So I'm thrilled that you're seeing the ability to leverage and scale that model. Congratulations to you and the team. All right, next team.
Next is California, Children's Hospital of Orange County.
Hi, everybody. Good morning and good afternoon, depending on where you are. And Erin and the Buffalo team, congrats. It's kind of hard to follow you guys because you've done a lot. You can go to the next slide. We're going to be dividing them up. Karen Pugh and I are going to each do half of the slides. So just a summary of our goals before we started with the Academy. So just looking at how patients and families can sometimes be confused or overwhelmed by how many people are involved in their care. They feel a little guarded when they're asked to repeat details that they feel like they've already given, or they may not feel the appropriate care team member is easily accessible. They're given a phone number or maybe a name, and they don't really feel like they're connecting as well as they should. So we set out to cultivate team dynamics amongst our care coordination team to streamline delegation of tasks based on scope of practice, and to overall improve care coordination documentation in our record, electronic record, which is Cerner or PowerChart. So that families felt like there was thoughtful cohesion behind each point of contact and it wasn't just random. And at the hospital level, the care managers who serve patients that are admitted may not be directly involved in care coordination outside of the hospital. So we wanted to improve the patient experience within that realm and across the continuum. And I would say there's a lot of words on this slide, but overall, we were really trying to optimize the coordination amongst our care coordination team. So coordinating the coordinators and then just trying to lighten the load for the families that we serve. Next slide, please. So this is a listing of our accomplishments and the progress we've made so far. So like many of you guys, we completed the FESAT with input from our parent partners, which was really enlightening. We held virtual meet and greets, mainly had them virtual because of the pandemic, but it was actually nice because we had a lot of participation because it was virtual. You didn't have to worry about people running around from different points on campus. So all just kind of got together at once online, just to better understand how each other's roles overlap and how to optimize communication. And that was just nice, putting names with faces and getting to know each other better. And collectively, we decided to implement the CCMT through our participation in the Care Coordination Academy. And we made our own, or chalkified, the Care Coordination Measurement Tool to put in our REDCap survey. So the REDCap was the online platform that we used for the survey. We piloted the CCMT, we edited it based on our feedback and expert opinions from different groups. And then we implemented the final version of the Care Coordination Measurement Tool. We had all 120 care coordination staff across CHOC use the Care Coordination Measurement Tool together on one business day per week for 5 weeks. So everybody did it together on Monday, everybody the next week on Tuesday, and so forth through Friday, just to get the variation in different days of the week. And we had over 3,300 care coordination encounters that were recorded in REDCap. And the results were analyzed and shared with our internal Care Coordination Academy team, then with the CHOC Care Coordination staff by their role. And then we had a large group presentation to present the results to everybody with breakout groups, which was really nice. Next slide, please. So I'm not going to go through all of our analyzed data, but this is just a snapshot. So you can kind of see one of the things that we did was looking at the distribution of time that different roles, basically looking at how different roles collaborate. And it was nice because we could see, this is just comparing two different roles. So we have our patient care coordinators who are more care coordination for more diagnosis agnostic. And then we have the care coordination, the care management assistants who work more closely with the nurses, which is division specific. And we kind of saw stuff that we already knew, but we were really able to see gaps here. So we could see, you know, why are certain groups working more with social workers and why are certain groups not? And why are we not collaborating more with mental health providers? And what's the deal there? What can we needed to delve deeper. So those are the things that we're kind of working on now. But it was nice because we were able to see where gaps existed and what we needed to do to fix those. So that's kind of where we are now. And I'm going to turn the slides over to my colleague, Karen Pugh.
Thanks, Dr. Carpinelli. And I'm so sorry, my camera's not working. Technology is not playing well with me today. So Dr. Carpinelli went over the collaboration and the results. And one of the other things we did was to ask the staff for more specifics in their comments about the care coordination measurement tool. And so to hear from them how much they really appreciated their roles being validated by the CCMT implementation was really good to hear. And then the second comment speaks about the complexities that lie within care coordination, and that unless you've done this type of work, you don't really know how long it takes to set up IV antibiotics, only to hear from an insurance company that is denied, and you have to go back and start all over again. And those efforts put in to make it happen, make sure that our families are heard, right? And that we get it right. And to capture that, be able to capture some of that in the CTMT really made the tool a valuable one to justify and quantify the work that the staff really does daily. And then the third comment really speaks to why we're doing the work. And it takes heart, right? And the gratefulness of having heart and showing compassion as part of the job that we do every day. Next slide, please. So we wanted to speak a little bit about the challenges, and it should come to no surprise to any of you that when we ask people to do something more than their work or the job that they normally do, that there are time limitations, just completing the survey, and the burden of the survey was always going to come up, right? And we have a large group of people between Dr. Carpinelli's group and my group. And so always a large group, scheduling issues are always going to be a part of the issues. And as we know, the pandemic has taken the world by storm, and some found themselves not working, families found themselves not working, not having the finances that they needed. And so that led to us with people having financial burdens. And so looking for those resources, being creative to bridge the gap for them and the needed social work services to mitigate the food insecurities, the housing and things like that really came in as part of the challenges. Next slide, please.
30 seconds, Karen.
So we had an exceptional leadership team that stuck together through this whole process with scripting and scenarios. And after planning our get-togethers to understand the different roles in different areas where people work, we definitely see that the team is working closer and working more collaboratively together. The team was pulled together one last time just recently over a real life complex patient situation to elicit innovative and creative ideas on next steps to take and how we could continue this work better together to serve our patients and our families. And I'll just stop right there because you can read everything else on the site. We had a phenomenal team. Dr. Weiss supported us. All along the way and every step of the way. So we feel really blessed to have the team that we have and work for the people that we do and our colleagues.
Thanks, CHOP team. You have a lot to be proud of with these accomplishments and several things that have implications for scalability. Remember, everyone, put comments and questions in the chat. Our team will track, and we can try to spend time at the end. Otherwise, we'll curate and send them around. But congratulations, Karen and Ann, and tell Michael that I said hi and congratulations as well. Okay, next team.
Thank you, Karen and Annie. Next up is community behavioral health in Philly.
Hi, everyone. So I'm going to be presenting with my colleague, Jessica Richter, and Dr. Turchi. If you want to chime in at any point on these slides, feel free. So you can go to the next slide. So again, community behavioral health is the Medicaid payer for behavioral health services in Philadelphia County. We are a carve-out state still in Pennsylvania. And we have partnered to implement our INC model with St. Christopher's Hospital for Children. So some of our goals were really, you may remember we had a failed, and actually St. Chris wasn't a part of this, maybe we would have gotten a grant, attempt to get an INC federal grant from CMS. And so we used the Care Coordination Academy to sort of adjust our flaws in our model and make it stronger. We used it to foster new partnerships, Title V, for example. I know Nick's always on and has provided a lot of great ideas along the way. Tools for screening, care coordination, and evaluation have been a huge benefit. Learning from others who've implemented an INC model. Some of the guest speakers were pretty phenomenal and the leadership of the Academy. Of course, now my dog is growling. It's like he knows I'm on a presentation. And then the last thing is using it as leverage to make this a priority. And so we actually used our participation in the Care Coordination Academy in our proposal to our state Medicaid office around this new requirement that we're using to implement our INC model. Okay, next slide. All right, I think one got, I think we're.
Sorry, Katie, hold on.
That's okay.
All right. Let's see. All right, this is going to you. All right, here we go.
There we go. All right, I'm going to turn it over to Jessica because she's boots on the ground.
All right, thanks, Katie. Though, if you or Dr. Turchi have anything to add, feel free to jump in. Katie said, I'm Jessica. I'm a clinical coordinator at CBH and overseeing the Inc. team now. So we've made many strides so far. Happy to say, I'm certainly still learning. So we did have our soft launch of the program at St. Chris, fully onboarded a team, including 3 clinical care managers. Those are master's level clinicians from CBH, supervisor and coordinator, that's myself, 2 psychologists and 3 behavioral health navigators from St. Christopher's, as well as family partners and medical legal partnerships. The CBH team has established an on-site presence at St. Chris. I will say, we're in 2 clinics there, special needs and the Center for the Urban Child. We started out at special needs part-time and then basically ramped up from there. It was a little bit of a smaller practice that Dr. Turchi oversees. So for a number of reasons, it made sense to kind of start there and then scale up, which we're still in that process now, although pretty much they're full-time. I think, this next bullet point is really the most exciting to me. The clinical care managers and navigators are working closely together and meeting with families and coordinating care. We're really seeing those interactions occur. We have started a weekly clinical meeting. It's possible we may, we'll reassess as we're going along if that needs to be restructured at all, but at least we've got a time and we've been able to delve deeper into some of the families that the interdisciplinary team is working with. And that meeting does also include our CBH pharmacists and psychologists from both CBH and St. Chris. So it's really an interdisciplinary clinical time. The team's completed several trainings already, have been great. Some of them listed out here with our 2-day motivational interview training being most recent. We'll have some ongoing work from the facilitators of that training. So just, some more things to have in our toolkit there. And then just through, some beginning numbers on there, so folks could have a sense. Each care manager already working with between 60 to 70 families. So we said the referrals are streaming in and the need is clear. And go to the next slide. And I'm trying to move quickly time. So some of the challenges, and I should say, a lot of the pros and cons are kind of two-sided. We all know COVID did not make anything easier. So clearly we were trying to, start this on-site kind of embedded program amidst surges and keeping, safety is first. I can say, even since that, a couple of team members on the CBH side have already had COVID. So we're then, dealing with coverage and whatnot, but we are working through all those things and being sure to adhere to everyone's policies. Likewise, I'm sure none of us are strangers to the staffing shortages. As noted, this does require on-site work, while there's many opportunities that are fully remote and folks may prefer these days. And I think this applies both to the CBH team and also as we are trying to get a behavioral health provider contracted to be on site at St. Chris. And, it's been somewhat of a challenge to staff that position as well. I think just, envisioning the model versus the reality of the day-to-day work, or some of us were in meetings for months, Katie and Dr. Turchi way before me even, and then myself, and we have sort of the idea in our head and then the reality of being day-to-day in busy clinics with a multidisciplinary team and, families with diverse needs, but we're addressing in operational meetings, we're revising the workflow as needed and as needed. I think, quick examples, we had thought the CBH team will review the list of patients coming in for well visits ahead of time, so we can really try to hotspot who we want to be sure to meet with. But in the Center for the Urban Child, where they may see over 200 patients a day, that is not really such a realistic possibility. So we're, reassessing how do we get back to some semblance of that idea while still being realistic and helping as many families as possible. Likewise, just communication between different organizations, different interdisciplinary team members, all of whom are busy. I heard the last presenter mentioned schedules as well. And, we need to meet to iron out those things, but also any time the meeting is some time away from clinic and patient time. So kind of weighing all that and considering and then also just managing the high need that we are seeing. We knew it was there and we're seeing it clearly. So we're excited this is going, but already thinking about the capacity that we have versus the need. And it's new, so we're tweaking it, and some of that is ensuring the referrals are appropriate. We see a few here that are not, and just assessing and monitoring and getting feedback from the team. Next slide, and I'll turn it back over to Katie.
30
Right.
seconds.
All right, no problem. I can wrap it up quickly. Basically, it's funded right now under a new requirement from our Office of Mental Health and Substance Abuse Services, but we are always thinking Plan B, just in case. You never know when the state changes their mind. So we'll have data that would allow us to switch it to an alternative payment model if needed in the future. We are, and Jeff, I see your question. I'll respond in the chat box in a minute, but we are collecting a variety of outcomes, and we'll use those outcomes to sort of strengthen and refine the program, continue to make the case of the value of the program. Of course, additional funding would be another thing that would allow us to pilot innovative interventions, address more social determinants, and really expand even within the St. Chris system and beyond. Right. So basically we're communicating with our state office of mental health, and also the physical health payers, because this is something they should be interested in as well. It's integrated care. So what are the successes? And we do have infographics in the work, and eventually we'll be adding in our outcomes findings on those infographics. I think that's it. Our team is at the end, including a team photo. So if you advance the slide, you'll see some of the boots on the ground folks doing this work.
This wonderful. And remember, comments and questions in the chat. Katie, Jessica, Renee team, this is really great. I want to call this out. This was the only team that came in pretty much focused singularly on behavioral health. Everyone else was thinking about broad notions of care coordination. And we're going to have to figure out how to actually integrate these things in a joint fashion. Because the wave of behavioral health needs across all the children in America has escalated and will not abate post-pandemic. So I tip my hat, Katie, to you and Jessica and to your team for thinking about this. I'm going to argue that every healthcare delivery system is going to need to have an integrated behavioral health component, and the tools and the measures are the same. So more to come. Thank you for that. All right, let's go to the next team.
So thank you, Katie and team. Next up is Team Indiana.
All right, and my name is Natasha McClanahan. I'm going to be presenting for Team Indiana. You can go ahead to the next slide, please. So some of the things that we were hoping to accomplish when we started participating in the Academy was just to really continue to refine our model, which is we have 3 nurse care coordinators located in primary care practices throughout the state of Indiana. 1 down south in a rural community, 1 here centralized in Indianapolis and then 1 a little bit more up north, but not too far from Indy, and it's a semi-rural location. And so through that, we were also looking to refine our coaching model, where we have a nurse and social worker who coach these 3 care coordinators on care coordination and provide didactic trainings and really spend an intensive 6-month process onboarding and providing these trainings for care coordination and then one-on-one coaching support. So we were really focusing on that and refining that model. We had other goals, obviously, as well, things like hopefully expanding this model through the entirety of the state. And here in just a second, I'll let you know if that was accomplished or not. Through Medicaid, we were also looking to, at the beginning, we were very unsure of what was going to be happening with our state Medicaid. So we were also really looking to partner closely with Riley's Children's Hospital here in the state of Indiana. And so partnering with them in this collaboration on what their hopes for care coordination would look like, we really wanted to be a part of that as well. So we can go ahead to the next slide. And so some of the accomplishments that we have been able to achieve throughout the time here with the Academy, we have received funding from Medicaid to expand our project into 24 other practices throughout the state over the next 2 years, and we begin next month. So the anxiety is skyrocketing, but we're also very, very excited to be able to announce that and to be able to continue to move this work forward with the assistance of Medicaid. So we continue, and we also continue to collaborate with the Children's Hospital on their plan to develop out care coordination, and they are in the process of 2 pilot projects in specialty clinics, and we continue to sit on groups and discussions. Dr. Ciccarelli continues to be very, very involved in that project, as well as myself and my colleague Lorena, and just offering insight and suggestions. As far as measurement goes, we've been able to, like many here, do the FESTAT and the CCMT tool, but we also, from our participation in the care, in the CMC coin, using family satisfaction surveys to really kind of check in and see progress throughout this time. And we're getting ready to get into our 6th cycle. But here on the slide, you see that we have made significant improvements with care coordination, with also our shared plans of care. And that is, we feel really heavily focused on how we're teaching our care coordinators to also teach their families and their interactions. And through the quality improvement reporting progress that we launched back in the fall of 2021, where we're really looking at, how making sure our families are receiving consistent contact through 90-day calls or, messaging and things like that. How are the care coordinators really keeping in contact with them? And then through 6-month shared plans of care reassessments and the shared plans of care, we're also auditing the content of those SPOCs. And so through that work, we were able to really kind of refine how are families seeing their shared plans of care, how are they utilizing that, and also how are care coordinators interacting with the families. And so that's kind of why we've been seeing these jumps in family satisfaction surveys. And the last point here, we've been able to really refine the coaching curriculum in our orientation week. Feedback surveys from new care coordinators that we've hired over the past couple of months. We've had 2 new onboarding, and they've given us great feedback on that they feel prepared and ready to jump in a lot earlier than we were anticipating. So that's great. Next slide, please. Some of the challenges, like many have shared, it continues to be ongoing work of engaging the families with their complex needs, this continued discussion on social determinants of health and, how to account for that. in the service delivery. We are working on developing out, because only one of our care coordinators right now, and then when we expand, it'll probably be even less, have access to social work. I am a social worker for this project, and once we expand to 24, it's going to be very, very hard for me to offer that support to other care coordinators if they don't have access to that in their clinic. So right now we only have one, but we are working with Title V on the possibility of that connection and working out a process to make sure that our care coordinators have that access and can get social work support. Another big challenge that we continue to kind of come up against, and we're working with over the next 2 years of really refining, is whole practice engagement. We have physician champions and our care coordinators at these primary care practices who are very engaged, but just really making sure that wraparound staff and other providers that are interacting with these families are also receiving the education and support that our care coordinators and lead physicians are receiving as well. Next slide, please.
1 minute, Natasha.
Okay, I'm almost done. So like I said at the beginning, we have received funding through Indiana Medicaid, and we are looking ahead at next steps. So we're looking at expanding not only to 24 other practices with nurse care coordinators, but also expanding our coaching and support team here at the Indiana University Pediatrics. So we are, looking to hire quite quickly. So just an example of what our, organization is going to start to look like over the next few months. Hiring an associate medical director, program director, really refining how we connect with the university's School of Nursing and in public health, and just how to build those connections out even further. And so with that, I will leave you with the next slide, which is our team, which will be growing very, very soon.
That's absolutely wonderful, and demonstrates again something that is, I think, really representative of the experience of this academy and for teams that are moving in this direction. So you've got some demonstration of value, what it takes. There's now a challenge to say, okay, get ready to scale it up. And that's not simple, right? Even though we should all be, doing a happy dance. I think that it's actually apropos that you kind of gulped when you said that, because we've got to be able to do that in an appropriate way. So thinking about scalability is going to be important, but sincerest congratulations. We're going to move on. There is a really important question that I specifically want to flag that Steve Fitton put in about the funding and the authority. So Natasha, if you're able to respond to that in the everyone chat, and if not, Steve, we'll have somebody get back to you. But once again, congratulations, really, really great. Next team.
Yes, congrats, Team Indiana. Next is Team Kentucky.
Good afternoon, everyone. I am Ivy Alexander, and I'm the Executive Director at the Office for Children's Special Healthcare Needs and Title V SHIN Director. And myself and Michelle Mara, she's the Division Director of Clinical and Augmentative Services here, we will be presenting to you today. So next slide, please. So just an overall summary of our goals for our team. We were one of the teams that started in the second year, so just last September we started, but basically looking at the reimbursement, the intensity of the based on the intensity of patients, the reimbursement that we're getting from Medicaid. We wanted to be able to get more parental input on our care coordination processes and the services that we were providing. We also wanted to provide more resources. So are they getting the resources they need? Looking at surveys to gain that data, gain that information. So we surveyed families in order to justify this enhanced need from Medicaid. And then again, the main thing we did this time was surveys. Next slide, please. And Michelle is going to go over our accomplishments.
Hi.
So for our accomplishments in progress, since we started, like she said, just last September, we're more in progress of all of our accomplishments, but we are working toward developing an acuity tool that will help us to determine which patients would be best served by the care coordination that comes outside of our current clinic model, which we have patients who come to on-site clinics, and we work with them and have a good care coordination model there, but we have patients that need care coordination outside of our on-site clinics. So we were looking at determining based on acuity how we can best do that. We also are developing the workflow process and benchmarks that our care coordination would include for patients who are not actually receiving their services in our on-site clinics. We've reviewed our current care plan and portable medical summaries, and we are in the works of determining really how we can best combine these two tools to actually have a better shared plan of care that'll work for our patients as they are out in the community working with their providers there as well. And then, of course, we implemented the care coordination survey, and that has been used to assist our team in really identifying potential needs and areas that we can grow. Next slide. And the survey, I will tell you, it was one of our difficulties was our technology in releasing the survey. You know, we've been working with technology throughout the pandemic, which we know to be a challenge, but in particular with releasing our survey, we had some struggles just with the Wi-Fi capabilities within some of our offices for the surveys to get out. So we found some new ways to get the survey to our families, which included using QR codes and that type of thing. And also learned a little bit about our families' abilities and education needs on how to do that. So, but we did, as you can see here, we did get 43 survey responses collected to our 22 question survey, and are continuing to implement that, and we'll continue to evaluate those surveys over time. Next slide.
So we have just a couple of slides with data on them. One of the things we tried to capture or learn is the scope of care coordination that's required. So one of the primary questions was the type of providers that our patients were seeing, the number of providers, and just the scope, the range, to just show that there is truly a need for care coordination. And then what are they doing now? I mean, what type of teams are they on? Or do they have team meetings? And then do they appreciate those team meetings? So those were two of the questions that just gave us the foundation for the need from the family standpoint. Next slide, please. And again, Michelle mentioned that we started a little bit, it was a little rough start with the technology, but once we got going, we were able to get some good data. The data that's shown here is basically just a sum total versus across time. So if we pull this data, I did look at one area to pull it across the time. So analyzing the results, a majority of our results started coming in March. January and February were really light, but in March, April, and May, we were able to see some changes. Next slide, please. And one of our goals is to ensure that families have the resources that they need. And so to ensure that our team of care coordinators also have that knowledge to share. So we wanted to know, what are the families receiving currently regarding resources, and how often are they provided to them? So we collected data on that as well. So overall with the data, we're almost half and half. And again, this is just a snapshot of everything, not necessarily across time. And our goal with the survey, of course, is to continue. We're not anywhere close to being completed, but over time we will see improvements in these areas. Next slide, please.
So talking about our challenges, and I know that this is a common challenge for everyone, but in looking at changing our current care coordination model, it's definitely challenging due to staffing. We've done actually a really good job of hiring recently, but there's still just challenges, as someone pointed out, with COVID contact tracing and staff being out, as well as just getting new staff on board and oriented. It does take time to do that. And at the same time, we're looking at our current model and changing that. And that takes time for our existing staff to really move to doing something in a different way, and truly understanding how we can provide the same level and quality of care coordination that we're providing in our on-site clinics, to do that in a model that is, I guess, essentially remote, or, not utilizing that same on-site model. Reimbursement for care coordination will continue to be a challenge. We are fortunate in Kentucky that we do have Medicaid backing for that. However, we'd like to continue and try to get the funding in place with our more commercial insurances as well, because that's about 20% of our population. Next slide.
Our next steps, of course, we're going to continue to enhance this program, even though the Care Coordination Academy is coming to a close. This is one of our focuses, is to really enhance our care coordination. It's something we've been doing for years. And so now we're learning a new way to do it and to implement it so that we can impact more children. We've got to do that, of course, with family input, focus groups, and continue the surveys. And also the care coordination management tool, so implementation and studying our results from that tool. We are so grateful for the way we're structured, where Medicaid is one of our sister agencies. And so they are right at the table with us and know the importance of care coordination, especially for children with medical complexities. We have a reliance on our data team, of course, that's here, and staffing. That's one of our, we need to definitely have a full staff of care coordinators and social workers. We are, of course, advocating for the need that we for needs, but the team here in Kentucky does understand what that need is and the value and the importance of care coordination, from executive leadership. Our cabinet secretary, we're a state agency, so our cabinet secretary used to be the SHIN director in Kentucky. The Medicaid director in Kentucky used to be the medical director here at the SHIN agency. So we just have a lot of team players that understand SHIN and medical complexities that are outside of us, but they are there to support us as well. Next slide is our team, I believe. And Sandra Gilbert, our family leader, and Michelle Mara have been very involved in really leading this team through this. Thank you.
Thank you, Kentucky. This is just so great. And we appreciate what you've brought to the Academy, recognizing that you entered in sort of phase 2. But what tremendous learning opportunity that you shared. So congratulations, and appreciate that. Heather, we'll do the next team now, please.
Thanks, Rich. Next up is Michigan.
Okay, so I'm gonna kick us off here. Marcia Franks from Michigan Department of Health and Human Services, and I'll be co-presenting with Teresa Christner and Tara Depew. So next slide, please. So our goals when we initially joined the Academy included piloting the PIC survey in our existing MDS clinics, which stands for Children's Multidisciplinary Disease Specialty Clinics. Sorry. And then we also wanted to assess the number and types of children with medical complexity currently enrolled in CSHCS, so that we had an understanding of what the population, how large the population might be. We wanted to support the availability of services for children with medical complexity statewide to ensure equitable access to services. We planned and have been exploring a health home benefit, which could provide complex care management to children with medical complexities. And then we also wanted to introduce care coordination and case management training to local health department partners in at least 2 training events. So that's basically a summary of what we plan to do by working with the Academy. I'm going to turn it over to Teresa to talk more about what we accomplished.
Okay, next slide, please. Thanks, Marcia. So here's our progress to date towards the objectives that we identified. For the PIC survey, we have created the PIC survey in SurveyMonkey, meaning that we had department approval and we have piloted it. We created business cards to promote the survey, which can be distributed at the clinic sites to families so they can complete it when it's convenient for them. And then we are actively recruiting another clinic. We spent a fair amount of time doing the data dig. Originally, we identified 4,479 children who had between 3 to 9 chronic conditions and met other CMC utilization criteria. Through our participation in the Care Coordination Academy, we learned about algorithms that helped us systematically identify potentially eligible CMC children. And so they do this by using Medicaid claims data. We have tried that now using the complex chronic condition classification system, and we liked it. And so we're going to move forward with that, I think. And then also as part of our data collection efforts, we wanted to be sure that we identified appropriate access points. So we mapped out where children lived and then superimposed on them where facilities were. We knew of 8 different facilities that were providing CMDS services. And so based upon those facilities, if we could recruit them to provide this home health benefit, we believe that we could address 92% of the identified CMC population in the state. So that's a goal to move forward with. So we'll continue to meet with stakeholders at these facilities to learn about their capacity and their interest in serving this population. And then lastly, or not lastly, we've done a comparison of the 2703 Health Home legislation. We compared it to the ACE Kids Act. We pulled together a RACI chart and a work plan so that we could scope out the project steps and all the resources that are needed. We've created a series of white papers and we're still working on those specific to like client enrollment and provider readiness and relationships with the Medicaid health plans, how to do rate setting. And we plan on applying for a state planning grant in October under the ACE Kids Act. And then lastly, we have completed 8 regional trainings with our local health departments that focus on care coordination. So the next slide, please. And so some of these are going to be redundant to what you've heard from other people. So I'm only going to really focus on 3. The one that really was, I think, difficult for us is the learning curve related to health homes, to identifying the cost of care coordination, to understanding billing and why the current billing mechanisms don't work. And so we need to be able to document that and answer those questions in order to convince leadership. I think that, you know, this is a program that we need to move forward with. There's a balancing act that has occurred. And I think that balancing act is not only just like looking at what our daily obligations are, but also in trying to understand about what our stakeholders wanted, because they wanted us to move quickly, and then also what our leadership wanted, because our leadership wanted us to move cautiously. And so that's a delicate balancing act that we had to maneuver. And then lastly, there's the challenge of the fact that they haven't issued guidance yet for ACE Kids Act, and that's been a little bit problematic for us. So we're working basically upon what we're seeing in the 2703 SPA and trying to answer those questions as a way to prepare. But in addition to that, there is the challenge of trying to create systems of care within already existing and sometimes changing systems of care. And what I mean is that the Department of Health and Human Services is currently addressing children and behavioral health issues, and they have an initiative called My Kids Now, which is different than ours. There are some major changes we think that are going to be proposed in the foster care system that could have some impact. We have new initiatives being proposed around respite, and then there are questions that we need to answer about TEFRA. So you can see where these populations and services may intersect. And so it's going to be not only then getting through all of the things that we need to get through in order to establish this benefit, but also then how do we make sure that things are coordinated and integrated appropriately. So I'm going to turn it over to Tara and she can walk us through that part.
Yeah, and you can go ahead to the next slide.
just want to touch real quickly on what we will be doing next. So how will we keep our work moving forward? As Teresa mentioned, we'll continue to seek a state planning grant under the ACE Kids Act. We did implement or created a RACI chart that really outlines all the different departments touched by our work, and we'll continue to work through that RACI chart. What do you need to continue this work? We have a lot of really big questions related to this project regarding non-reimbursed costs associated with providing care coordination and just an understanding of the billing practice. So to kind of addressing the last question, we're really going to be working with different departments to better understand some of these challenges. So we'll be working with MSA policy to better understand CPT codes that are available to providers to bill to, working with provider support to understand how those providers can maximize their billing opportunities. We continue to work with Partners for Children to better understand their billing practice. We'll also re-implement the CCMT to determine the amount of non-reimbursable services that are provided through the Partners for Children program. And then we're excited to continue our education through our participation in Project Accelerate. So if you go ahead and go to the next slide, I believe this is our team, and it's been constantly changing and evolving, but here are all the happy faces that are making this work possible. And that's all.
What a great team. We're unfortunately at time, but I also want to congratulate the Michigan team, which really great as you've done some of the local blocking and tackling. You're paying attention to things that are happening out in the ecosystem, like ACE Kids and things that I think many of us are trying to figure out what they're looking for there. And so I think I commend you for being granular, but also being strategic. So congratulations to the Michigan team. Let's go on to the next team, please.
Yes, thank you, Team Michigan. Next is Minnesota.
Hi there, this is Rhonda Katie from Team Minnesota, and we are located in Gillette Children's Specialty Healthcare in St. Paul, Minnesota. Next slide, please. So we had big goals for participating in the Care Coordination Academy. And like Team Indiana, I'm not sure if this was mentioned, we participated in the CMC Coin Project. And so this was our participation in the Academy grew out of that. So as a team, we had been working together for 3 years prior to starting the Academy, which really gave us good insight into what we needed to do. So our primary objective, we knew our complex care program wanted to provide care integration and was working towards that, but we had no measurement in place and we needed to do that. So our primary goal was to measure family experience with integrated care, care coordination and integration tasks, and then our commitment to sustainability. We also had a few other goals, which I listed here. Goal number 5, we really sought or felt that looking at the health service utilization for our complex care enrollees would give us a better idea, help us with our measurement goals. But because of limitations on our accessibility to claims data across the continuum of care, and how can I say, legislative limits on how our Medicaid claims data can be used. That just wasn't a reality. So we dropped that goal pretty quick. And we also felt that this would help us align to that with the ACE Kids Act requirement. But Minnesota, last I heard, was still on the fence regarding opting in. So that goal went on hold also. Next slide, please. So our first goal, measuring parent perception of care integration. We did this, we had a measurement tool as part of our CMC Coin project, which was very well developed, had good family input. But for our complex care program, which is a tertiary medical home, not primary care medical home, it just didn't capture everything that we needed it to capture. So once the coin ended, we took the National Care Coordination Standards that had recently been published, and we knew we wanted to use the PICS survey and the FECC survey. They're both really good tools. They measure really different things. So basically, we ended up with a consolidated survey, uses the majority of the PICS core questions, a handful of the FECC questions, mostly to measure accomplishment of certain things or tasks, and then a few questions from the National Child Survey. And we started collecting the data in February, and just in these few months, have 70 completed surveys with a really good response rate. And what was most important to me is everybody answered every question, which indicated some acceptance that our questions made sense to parents. We're still in the process of analyzing the data, so I'd hope to have something for today, but I don't. And I'd be happy to share this with anybody who's interested. Next slide. Whoops, we lost one. Or did I? There. Oh.
Hold on, let's see. I have you from this
Okay.
one.
Our care integration tasks. Uh-oh.
You want me on this one or this one?
Oh, come. Why don't you go the next one? Maybe I'm missing. Oh, God darn it. I'm missing a slide. Oops, I lost a slide. Anyways.
If you have your slides up, I can let you share if you'd like, if you're. But I'm not-
Okay. I'll just talk through it.
Okay.
So the next thing we did, we wanted to measure what were our providers, what were our care managers, what were our appointment schedulers, and what were our parents doing in terms of care coordination tasks. So we took the CCMT and we modified it a bit for each of those groups. And we started collecting data about the same time frame, January, February of 2022. And what we found is for our providers, they may be reimbursing or getting reimbursement for about 30% of the time that they use care for this population. Because again, they can at least at Gillette, we're only billing for activities that happen on the day of a clinic visit. That's about 30% of their time. 70% of the time is spent before the clinic visit or during clinic visits. For our care managers, our findings were what we expected. About maybe 35% of their time is spent doing what I would call proactive care coordination, developing plans of care, proactively reaching out to parents, helping with education, shared decision-making. The rest of it is more reactive. And the bulk of that is communicating either internally or externally with clinicians. Because a lot of that is done by email, certain messaging, phone, takes a lot of time. So our goal is to, kind of flip that. There's more proactive care. And then if you can go back one more slide, just go backwards. Yes, whoops, with the care map. Whoops, there we go, right there.
Okay.
So then our last biggest goal was our commitment to sustainability, to kind of have, we've got a value proposition. And so how do we have all this data collected, but how do we make not only our internal leadership, but state legislatures understand the complexity? So we took a page out of the care mapping book, and we did this in PDF. This was one of our family reps' child, but it was to illustrate all the things that are needed to keep a child and family happy. Bottom line, good quality of life, good family well-being, and also then highlighted what the complex care program helps with, which is a lot, but there's still a whole lot out there that the family has to do. And so that is really what I didn't speak about when we were talking about the care coordination activities, was collecting the data from parents. We really wanted to be able to document with data, again, to take to the whomever will listen to us, is the amount of time that families spend. Even though they're getting all this support in the complex care program, there's things that nobody else can do. And what we're learning is the bulk of the time is spent providing care in the home, because there's no home nursing available, or it's unreliable. Next slide. Our next steps is to talk to our leadership, develop a package to take for our lobbyists to take to the state legislatures. We're also advocating for plan of care technology. We don't have, we currently use Cerner, the base package. Our plans of care are a Word document right now because there's nothing within Cerner to support that. We also do not have a good patient registry. It's an Excel document. And then we're also, what Medicaid claims data we do have for a small subsample through a value-based payment program, we actually now have somebody looking at that data just to understand service utilization. Are there areas that we don't even know about where our complex care patients are getting care from that we could be doing a better job coordinating, serving, however. And next slide. And this is our team. What was nice about the Academy is it allowed me to get organizational support to pull in our financial planning people, our program development people, our lobbyists. And we also then were able to pull in our Title V people who are active in our COIN project, but Title V at a higher level, and also our Medicaid folks. That would be the last person from the Minnesota Department of Human Services. And that's it.
Rhonda, thank you. Really, really great work. And I'm hopeful that in the years ahead, a couple of those things that you've called out, having a technology-based a plan of care and a registry that is relatively hardwired into EHRs is coming. I will put a link in the chat to some recommendations that will be coming out of the National Quality Forum in the next few months. In fact, providing guidance to the Centers for Medicare and Medicaid Services and the Office of the National Coordinator on EHR source care coordination, care communication recommendations. So more to come. We're going to go to the next team. Rhonda, if you could answer Annie Carpinelli's question about the response rate, it's in the chat.
Oh, so Ann, what we did.
No, if you could answer it in the chat, because we've got to move on.
Really?
Thank you. Heather?
Next up is Team Montana.
Thank you, Heather. I'm Kim Brown. I'm with Team Montana. And as we've said many times during these Academy sessions, when we talk about our team, we're quite different from the other teams in the Academy. We truly are Montana, all of the state. We're not a single provider entity or a hospital. And so next slide, please. The folks who originally asked for Montana to be allowed to join the Academy established two goals. The first was to come up with a statewide understanding of what a fully functioning medical home looks like so that we could all be on the same page, if you will. And then to establish a pediatric care coordination framework that could be adopted across the state. I think our team would probably all agree that we were pretty successful in meeting our first goal. The second goal is still quite a ways down the road. And then we had a number of outcomes that we hoped would flow from achieving those goals, including meaningful parent and family and youth participation in their healthcare decisions, increased health literacy, better understanding of the systems, and enhanced communication across the systems and providers. And I think particularly with respect to that final outcome, we really have been able to achieve that both through our participation at the national meetings and also through the monthly Montana team meetings that we've held throughout the duration of the Academy. Next slide, please. Some of the accomplishments that the Montana team has made over our participation include coming up with a one-pager and the Mother's Day card that we were asked to do quite some time ago. And those were useful for us in terms of recruiting additional membership to our team and trying to make sure that everybody who was participating in the team meetings understood why we were there and what we were hoping to accomplish together. One of our most exciting accomplishments, and this was in large part due to the great assistance of Linda Starnes from Florida, who I think is on the call today. And it was through the Academy that we were able to connect with Linda again after having heard her present several years earlier. And she agreed to come and help us set up this family-led parent panel, which we presented to our Montana team and then later took to our Friday Medical Continuing Education Conference for Montana providers and put it on as a Grand Rounds. And then out of that created a family-led Grand Rounds template. We also were able to collaborate really closely with our Family to Family Health Information Center. We have several members of the center also on the call today who are members of our team. And again, that I think was one of our proudest accomplishments during our participation in the Academy. And it's a model that we hope to continue to move forward with and use for other topics. We also implemented the care coordination maps. We had 2 Masters of Social Work students work with families to create maps for a young child and then for an older teen as a way, again, of educating our team members around the complexity that families and children with special health care needs are dealing with every day. Again, a lot of our work is building the framework so that we can move forward. And then we had 2 Masters of Public Health students develop and disseminate a statewide care coordination survey looking at how do providers and hospitals and agencies around Montana define care coordination, who's providing those services, how are they paid for, what are they called? And this, again, laying the groundwork so that we can move forward with figuring out what kinds of care coordination models will actually work in our very rural, very geographically large state. And then our final accomplishment has been our monthly Montana team meetings, at which we've had different agencies, entities, providers, payers around our state present about their initiatives and what they're doing. So it's really been a great way to network and learn more about what's available in our very frontier and rural state so that we can figure out next steps and really position ourselves well to take those steps. Next slide, please. Our challenges, I think, are very much the same as what you've heard from other states. The pandemic-related priority shifts that pulled people in and out of team participation. Our state is the 4th largest geographically in the nation, which makes, even during non-pandemic times, which makes coordination of any kind pretty challenging and limits access that people have to services. And again, because our team was statewide, we have competing health organizations. We don't have a single care coordination entity that we're trying to work with, which also means we have incompatible electronic health record systems. And so trying to deal with that and some communication challenges around that, inadequate incentives for providers to provide care coordination. We have significant behavioral needs, as again, many other states have mentioned. And we needed to bring team members up to speed on what the system improvement benchmarks and measures even look like. Next slide, please. So in terms of our next steps, we feel like we've laid a very nice framework. And at our May Montana team meeting, we asked if folks wanted to celebrate what we'd accomplished and just sort of head off into the wind in our separate directions. And the answer was a resounding no. People want to continue working together and actually take the next steps. So that was exciting to those of us who have been coordinating the team to hear. Our next steps will include increasing the provider and payer involvement so that we can really look at, okay, what are the models that will work in Montana? Bringing in more medical professionals, identifying overlaps and duplication, conducting the screening for social determinants of health, making sure that we have connections to the resources to address those needs, data. And then a key piece, and I think this touches on what we just heard from Minnesota, our Family to Family Health Information folks have reminded us many times that families are the ones who will always be there providing care coordination. And so whatever we can do to help families build their care coordination skills, we want to do. They are the one constant in this, and they are the ones who, even when all of the other systems fall down, they're the ones who will have to provide that coordination. So what can we do to help families understand their role, and how can we support them in that role? And then the final one is partnering with legal experts who can help address social determinants of health areas that might have legal remedies that we're not able to get changed through policy. Next slide, please. Our original team consisted of, or our team leads included Dr. Halexa and Martin Blair, who was the director, and just his last day was actually Friday for our UCED, or our University Center for Excellence in Developmental Disabilities. Now Mackenzie Peterson, who is our Children's Special Health Services Program Director, and myself are the team leads. Our original team had 37 members. We've shifted over time. Again, it reflects the nature of us being a statewide team. And you'll see just some of our partners on there. And that's all I have. Thank you.
So Kim Brown, this is not intended to embarrass you or your team, but hooray. What most folks on this call that aren't from Montana, although Linda, you might know this since it sounds like you were a bit of a guardian angel. Kim, I remember speaking with various members of your team at the beginning, but Rich, we were just new. How are we going to catch up? And one of the things that Meg and I and our respective teams were saying to Anne Marie Padlin and our colleagues at the MCHB is we have to meet the teams where they are. And I think that Montana came in being authentic about just how far upstream you were in the process. And what's really humbling, and I find very, very exciting, is how you have met these challenges and moved to position the state and the key stakeholders across the program for what is next. So you've actually taught me and us something critically important. We have to be ready wherever delivery systems are, providers and stakeholders, meet them where they are, provide a roadmap with the necessary interprofessional training and measurement. So congratulations, Kim, and you know, having a couple of people pivot as well. So you've kept it going, and I'm grateful and proud to have been an advisor to your team. Thank you.
Thank you very much.
Thank
Heather,
you, Kim and team.
Next.
Yes, next up is Cincinnati Children's Hospital.
Okay, yes, hi, I'm Janetta Thomas, one of the nurse coordinators at Cincinnati Children's Hospital. You can go ahead to the next slide. And for our participation within the Academy, we actually, the year prior to joining, we had actually completed the PICS survey. That was back in 2019. So we really, by joining the Academy, wanted to build upon that data. We also wanted to enhance our relationship with our local Spina Bifida Coalition. And then we did learn use of the CCMT, so we wanted to use that within our clinic, and then also to collaborate with some of our more local organizations here that was already in place at Children's, the Ohio Parent-to-Parent and the Family-to-Family groups. Next slide. As far as our progress with that PICS data, we did build on that information. And so we were given data to help us that showed that we needed to help on connecting families between clinic visits, not just while they're in clinic, but then to help support them as well between one visit and the next. So by learning of the family engagement assessment tool, we again learned of the family support that's needed for the impact of the child's diagnosis of spina bifida. Also the need for active tracking for our lost to follow-up families and helping them get back into clinic as well. So results from the FESAT, we did have improved scores after our interventions were put into place. We'll talk about that in a moment, but we also used that care coordination management tool that we still currently have in progress. We did receive that template tool, and we have adjusted it for our clinic. We've actually trialed that adjustment, but we've had some changes in staffing of our research coordinators of who we would use to help with data collection and input of that data. So we're hoping to institute the CCMT coming up this fall or winter. Another idea that we are working on is to develop an electronic registry. We use the EPIC computer system for electronic health records. And with the registry, our goal would be to help as far as the nurse coordination role, but also with our medical assistant and social workers who goes through our patient list prior to each clinic. And we pull the data, the information that's needed, requested from providers. But having that registry would definitely help in putting everything, kind of keeping it all in one place to make it easier to find that information. That next slide. So this is just information again of our Ohio Parent to Parent and the Family to Family organizations. They were already in place here at Children's, but we did not have a direct connection with them. So through the Academy, we were inspired to reach out directly to them and make that connection. The Parent to Parent is a group. They help to support parents for children with any medical complexities or special health care need. To kind of just be a resource and support and bounce ideas off, that kind of thing. Family to Family is similar. They work more as far as with caregivers and extended family members. So we now actively make connections for any of our families that we see who may be struggling or who would like to have that extra support with our resources here within Children's. Next slide. On the family engagement, the FESAT tool before our initiative, so we instituted that was October of 2020. We had 3 providers, 3 parents who completed that. And the results of our FESAT there had told us that families felt that they had information, although they didn't know how to act upon that. On the provider side, we thought we were being transparent and giving the information out to the families that was needed, but for some reason that connection wasn't being made. And so you can go on to the next slide. On the post initiative, those scores were higher. We had instituted, for instance, one of our initiatives was the flyers and announcements about classes that were being held within the department. Initially, we would just hang those flyers in the elevator, but again, when we asked families about those classes, they weren't aware that that pertained to them, or maybe they didn't see the flyer. And so now we actively print those and give those out upon discharge. So with our active visit summaries, so they're in their hands. And then they also are sent out via email through the listserv from the department. So again, that's just another way to get them directly in their hands. Next slide. Another initiative that we had was the Clinic Connect. So we formed this with our local Spina Bifida Coalition here in Cincinnati. Pre-COVID, the plan was to have the Spina Bifida Coalition come in person, and they were going to offer lunch in between the morning of testing and afternoon of our clinic. So they would be available again with lunch, and then they would have resources to be able to connect families if there's need for bill pay or transportation or whatever the need may be. They would be there on site in person. When COVID happened, we had to kind of move away from that, and so we went more of an online resource. So the Spina Bifida Coalition created this link to where families could log on through their personal cell phone, or we did have a tablet in use they donated for clinic that families could log on while they were in the visit, be connected virtually with someone from the Spina Bifida Coalition and still have access to those same resources. The results of that, it wasn't as well uptake as we thought would be. There were only about 3.5 people who connected over the 8 months time that we had it in place. The reason we still aren't for sure, we have used our parent advisory committee to kind of help us through that, but hoping we are now in communication with bringing that back as an in-person model now that COVID restrictions are kind of lifting, so that hopefully we'll have better response as far as that goes. Next slide. We also had created our Spina Bifida Patient Advisory Committee, and this was one of our
1 minute,
requirements.
Janetta.
Okay, one of our requirements through our Spina Bifida Clinic Care Partner, but we do have the advisory committee now in place, and it is active. You can go to the next slide. And down here at the bottom, just some of the things that we are working on as far as the advisory council. So we've done advocacy through Capitol Hill for COVID-19 vaccines for caregivers. We've also updated our website, welcome packet, diagnosis day brochures for our families. The clinic support, we're revamping that. We also have a library within our department, which we are now updating to provide book delivery to our families while they're waiting in our clinic room. And then we're also discussing building accessibility entrance. So we don't currently have automatic doors for our families. So we are in discussions going through that, and then also working through our scheduling issues. Next slide. I believe that's it. I talked on that. You can go on to the next slide. And then just we've worked through kind of our time limitations. We've added on meetings within our already standing meetings, and then again, using our advisory council for any patient resources. Next slide. And then we'll just continue this work as we are. We do have things in progress. And then I believe the last slide is our team. Yep, and that's everything.
And Janetta, thank you for that. You've mentioned it here, but I want to really call it out to all of the other, let's call them more traditional state teams that have joined through the CMC coin. The Spina Bifida Association has been working with the National Center for Care Coordination technical assistance now for a few years at the organizational level. Judy Thibodeau had this idea of, gee, could we bring on clinics and have them be the teams? And so you've just seen the presentation from one of those teams. But I want to flag this for those of you that are state team leaders and any of our federal partners that are listening in. The Spina Bifida Association actually has a clinical guideline on care coordination. Similar work is being done in epilepsy, and Child Neurology Foundation, et cetera. So I'm excited to be able to share that another key stakeholder would be these organizations that actually have very specific focus on patients with special healthcare needs, and the tools are relevant. So again, Janetta, thank you for the engagement, and particularly, I really am thrilled about the fairly unique structure that the SBA team brought to the Academy. Thanks. Heather?
Thank you, Janetta. I have a placeholder. I wanted to see if the Spina Bifida Hershey team is available to present. I think Denise, you're on the call. I apologize, I don't have your slides loaded up, but wanted to see if you happen to be available. If not, I can go to the next Spina Bifida team, which is Kansas City. Denise, are you here?
Yes, I'm available. I thought I just sent you a message. I just saw it, so I apologize. I sent them to Judy and didn't send them to you, so I do apologize.
That's okay. Do you have your own slides? I can stop sharing and let you share.
Yes,
if you'd like.
I can share.
Perfect. All right, let me stop and I'll give you the floor. Okay.
I gotta find it. Okay. Can you see that? Okay. So I am the social worker for the Penn State Health Medical Center, the Spina Bifida Clinic, and our goals were the care coordination, interdisciplinary training, development, and implementation of care coordination performance, and to establish a PFAC. We did have a patient family advisory council for the hospital itself, but specifically we needed one for Spina Bifida. So our team, which consisted of
And Amy Link, who is our parent and the family advocate, Sierra Smith, who is the patient advocate. Jolene Keller was our nurse coordinator, but so she's no longer with the program. And then we also had myself and Becky Griffith, who does care management in the main hospital, and then Maureen Manning, who is our director. So we had a few of us fill out the FESAT, and all the answers were compared and decided that our clinic would definitely benefit from a PFAC. We had our first meeting in October of last year and have had 3 total. And I feel that it's been a big success. One thing, and I probably wrote this later, is that we need to have more individuals, the patients themselves, be part of the PFAC. We do have about 10 on the roster, but a majority of them who said they'd be willing to be a part of it are family members. So now we're just trying to incorporate getting more patients involved. We do have, when we do our meetings, we've had speakers. So we choose sometimes one from the medical field and one from the community and go from there. The previous nurse coordinator created an individual care plan that the patients could access. So when everybody was done entering their notes for each clinic visit, the nurse coordinator would compile a 1-page or 2-page document, very brief, but the patient was able to access it via their portal, and it summarized what each specialty said about their visit. And we felt that was very beneficial because then they wouldn't have to go through, we have neurosurgery that's a part of our team, orthopedics, urology, physical therapy and occupational therapy. So, and myself, and then the nurse coordinator, if she had any, and we always put where they received their supplies and any DME needs that they had, who they received their supplies through that as well. So that was really, it was really beneficial for the patient. Now, unfortunately, like I said, we don't currently have a spina bifida nurse coordinator, but we are getting one. She'll be starting on, I think it's July 18th. So we hope to continue doing that. We completed the PICS tool and decided that transitioning and supportive services were 2 major topics that our clinic would like to address. And within that PICS tool, we chose 40 random families. We are a clinic of about 600 now, and we chose 40 families. We tried to go, I think it was almost a 50-50 between men and women. We tried to do transition. We tried to do patients. We tried to do family members, just to get a broad, different races, to get a broad view of everything. So that helped us to kind of figure out again that we needed transitioning, and we really needed to beef up our supportive services. And anybody who works in the field realizes that supportive services are kind of laxed across the board, but we wanted to put whatever we had together and make a document. And so I just created a 22-page adaptive resource list, and it consists of sports, activities, camps, and everything that would help our patients. And it is arranged. The first part of it is arranged by county, because I was realizing that I would look for resources for specific counties and there were none. So I said, well, might as well look for one surrounding. And then also people gave me resources for adaptive, like if you wanted to bowl, or if you wanted to play billiards, and or if you wanted to golf. So we did all of that. And the next step, and I sent it out last week, was I broke it all down and we asked that our PFAC members please verify that all the contact information is correct. So by our next meeting, we will have a document that's all up to date, and we'll be able to give it out at our continuing clinics. The challenges was, of course, Jolene left her position, but again, we're getting a new one, and just time to work on specific projects. Again, it was just Jolene and I, and for having over 600 patients, and we continue to get new individuals, it's just hard to really do as much as we would like. So what we continue to do as much as we can. So we're happy with that. The next steps is we'll continue with our PFAC meetings quarterly, and continue to bring concerns and needs to the team when they arise. And with our PFAC meetings, we do have a representative from the Facebook page called Living with Spina Bifida in Central PA. So if there are alarming concerns, which you just had one about a DME company, a durable medical equipment company, they'll bring it to my attention. just so that I can address it. We don't want it to be like he said, she said, and we don't want to be tattletale, but if something's very alarming and everybody has a very specific problem, it's nice to have that communication. Continue to work on our transition and process and our packet. It's a big thing I want to work on next. And also to get our patients signed up with the patient portal. Not everybody is signed up, but that makes it easier for everybody to utilize their individualized care plan. I will continue to work on and hope. I know the social worker like 6 years ago, which was right before me, had established a schedule to set up times to discuss transitioning with spina bifida patients during the workday. So that's one of the things we would like to work on, and possibly have a Zoom training about transitioning for spina bifida families. We will repeat the PICS and analyze the data in about a year from now, a little over a year. We would have liked it done it sooner, but it just didn't go that way. And like I said, talking to the new nurse coordinator to make sure that, see if she's on the same page with doing the individualized care plans. It's what's best for our patients and makes it easier for them. And we will continue to hold our PFAC meetings and then again, bring all our voice concerns to Elias Rizek, who's Dr. Rizek, who's our clinic director, and then our Care Coordination Academy director, Maureen Manning. And that was our small but mighty team. And that is it.
Thank you, Denise.
That's wonderful. Congratulations. And again, thinking about SBA coming in as a series of different teams. So talk about heterogeneity and diversity. We have about half a minute left. So I'll ask a question. Caitlin Woodson put the Spina Bifida Association Care Coordination Guidelines in the chat so people can see them now. And then Erica, Heather, and Jess and the team will make sure everybody gets it. But here's my question. How much did those guidelines influence your work, or was it the other way around? You know, that what you guys were doing influenced the SBA? Oh, did she drop off?
So Rich, this is Judy.
Judy, yes.
So
go ahead.
are you wondering about the Clinic Care Partner standards were influential, are influential in, these clinics are all partners. And one of our really most complex standard is the care coordination standard. As you know, you've had input into that. So that I do believe influenced the clinics, as well as the requirement to have a PFAC. Most of our clinics didn't have a specialized spina bifida PFAC. So now what they're doing is, certainly we have shared this, as you know, at a clinical care meeting, and what they're doing will be influential, I think, to more of our clinics going forward.
Yes, and Judy, it's just, I wanted to be able to do this, and Heather, whether it was you, Eric, or Jess that put the teams in this order, it was really brilliant. So here's an example, everyone, of clinic teams in different states that are linked together through their organization, in this case, Spina Bifida Association. And they have collectively made a decision that care coordination is really important. We're not necessarily going to wait for Medicaid or wait for our organization. So here's another way of building this up from the grassroots. So Judy, I want to make sure that we get that kind of commentary, and we're not going to have time to do it now, but would love for SBA to feed into the final evaluation report with recommendations to say, you know, here's what we did to make this meaningful for everyone in our space. So thank you for that. All right, Heather, let's move on.
Okay, we have our last Spina Bifida team, Children's Mercy Hospital.
Hello, I am Caitlin. I'm the nurse coordinator for the Spinal Differences Clinic at Children's Mercy, and I am a team of one. You can go to the next slide. Our team goals for participating in the academy. I was not present for the first year. I took over this job in April of 2021. But after hearing about it and taking over the slot from Denise, previous coordinator, my goal was just to learn as much as I could from the other coordinators, since we do follow such a strict set of guidelines. And then a second goal was to be able to share ideas and improve clinics all over in any way. And next slide. Perfect. My accomplishments of progress. First, I had to put the PICS survey into REDCap manually to prepare it for distribution to our patients. It's a very long survey, so that did take me a couple days. We plan on a September rollout after we have our newest physicians start, since we've been very short-staffed, and so we don't think we would get very accurate data at this time. And then secondly, we completed a 4-month A3 workshop on accessibility, and I've been collecting data on how different methods of preclinic reminders affect clinic day of show rates, such as letters, reminder calls, reminder texts, etc. The most recent set of data is from preclinic phone calls, and I've included some of the data below as far as how many people answer the phone calls versus how many people show up. Next slide. The biggest challenge that I face is that I am one person, so all projects and studies fall to me to accomplish. I am the nurse coordinator for about 472 as of last week kiddos. I do have 2 medical directors for my clinic, but of course they are very busy as well. So I've worked on improving my time management skills and also working on what projects to prioritize for the greatest benefit to the patients, because that's what really matters in the end. Next slide. My next steps and needs. My team will keep going after the academy. Luckily, my A3 process involved the Berry Institute, which is our educational institute at Children's Mercy. So they have regular check-ins regarding progress and data, so they bother me quite often. And then the PICS survey is something of interest to the Spinal Differences medical directors. They will ensure that I do not forget to get it out in September. What do I need to continue this work is support from the various members of my team at Children's Mercy and possible support from the other coordinators that I've met through the academy for questions and advice, and I know that they're always available. And then I advocate through my manager and the medical directors. The medical directors for Spinal Differences at Children's Mercy are Dr. Nicole McCartan and Dr. Michael Partington. And I also know that I can reach out to Judy Thibodeau anytime I have questions. Next slide. And my team is me as the nurse coordinator. And then I went ahead and included Dr. McCartan and Dr. Partington since they know the stuff I'm working on.
Caitlin, thank you. And this is really a great demonstration of the power of one. But if you're in an ecosystem that needs it, and then also, the organization is known for its work, especially around integration. So kudos to you and thank you. All right, Heather, let's move on to the next team, please.
Yeah, last but definitely not least is Team Texas.
Hi, this is Rahel, and I will present our team's report. I'll keep my video off because I seem to have an unstable internet and just to preserve some bandwidth. I don't know if you can hear me.
We can hear you. Perfect.
Yeah, cool. Yeah, it's great to be the last, partly because it just was remarkable how much overlap there is in all of the things, our challenges, our next steps. And I'm sure you all at the Academy will pull those threads together. But to get to our experiences, if you can go to the next slide. So in Texas, our goals for participating in the Academy was to create this, incrementally get to this integrated care delivery model, or the whole child visits that brings the family and the key individuals that serve them together to discuss person-centered goals, come up with an individualized care plan.
Oh, Rahel, I think we just lost you. Can you hear me? Is there anyone else from Team Texas? Rahel, can you hear me?
Yes.
Okay, you just broke up a little bit. We just missed the last maybe 20 seconds.
Okay. Yeah, I'm sorry about that.
That's
so we
okay.
worked with state and MCO partners to come up with an alternative payment model that would support these kind of visits. We also wanted to submit to work on 3 papers for publication, some of which would be summarizing our preceding work with the COIN, and then the ongoing work with measuring care coordination. We also had built a very large partner stakeholders that were meeting pretty regularly, which had really been a great stakeholder collaboration that started with the COIN, and we wanted to make sure through the Care Coordination Academy, we kept this large partners team together to permit more innovation supported by Medicaid as well as the managed care organizations. We wanted to also work with our executive leadership to find budget for parent stipends within the clinic program budget, partly because we had had an unprecedented level of parent leadership in these projects, and we wanted to make sure that was sustained even after the grants expire. And then we also had this great collaboration with the University of Texas Dell Medical School, the Value Institute, with parent work groups, with Texas Parent to Parent. And primarily the Value Institute input was very instrumental in working with the family leaders to figure out an evaluation that was very specific to these new visit formats that we were trying to create. Next slide. So we had several accomplishments. To summarize the big ones, there was a request for information that the Texas Health and Human Services Commission had put out to asking for care models, ideas on care models. We used our stakeholder team to have multiple meetings, brought a whole lot of input from individuals in academy, advisors from the COIN, from the medical school, a lot of involvement from parent groups, and put together a document that is, we hope, will serve as a North Star that would align the Health and Human Services Commission policies and pilots that will be coming down the pike. And since the submission, we've had multiple meetings with Texas Health and Human Services Commission and other partners to see if the ideas that were articulated in this document could be piloted using the vehicle of the ACE Kids Act. Where we are right now is that Texas will implement the ACE Kids Act, but it will not be calling it ACE Kids Act. It is kind of part of it is because they don't want to pull the federal 6-month money. They are worried that it would put them on the hook for funding it going forward. So we're struggling with this situation where there is legislative direction through a lot of advocacy from our stakeholder group, legislative direction that Texas will pilot something similar, but it's not going to be called ACE Kids Act, and money has not been allocated for it. So there's a whole lot of advocacy going on still. We did get some funding from a local foundation, Episcopal Health Foundation, to pilot this whole child visit. And we put the technology infrastructure in place, refined our care plan app, and ways for families to also write their own story. And we pre-piloted 10 families and also did focus groups to get the feedback both on their experiences of the visit and also the questions that were designed for survey by parents. And we're right now in the process of modifying both the structure and workflow of our visits, as well as the format of the surveys based on that feedback. We are very focused on trying to identify how to measure what really matters to families, and we are relying heavily on the Value Institute in collaboration with the family work group under the leadership of Sherry Santa to define that. We are in negotiations with one managed care organization to have a per member per month payment for these twice a year visits for that we're calling whole child visit. Next. Challenges, it just mirrors what everybody's challenges are. I start from the bottom, the bandwidth of the team. I think it is sort of like an extracurricular activity for all of us, because there's the day job that takes 150% of time. And then we have to commit this time, incredible amount of time for this transformation project. So there are competing priorities at the clinic level, at the MCO level and HHSC level. We have to sort of build the plane as we fly it, because there are certain requirements that are almost in contradiction to some of the workflow that we want to do, but we are bound by contract to do those things, which take time and bandwidth away. The payment model is still lagging, very behind.
30 seconds, Rahel.
Okay, yeah. The payment model is lagging behind the service delivery model. Despite the refinements in the shared care plan, there is really no payment to support that. And we're still hoping to finalize that negotiation in the coming months. We had some delay in the technology solution. We had our technology platform connect to our EMR, but we had wanted it to connect to the MCO, to Blue Cross Blue Shield's EMR, to facilitate the delegation that we had taken on, and that it had taken longer than we thought. Next, we will continue with this partners. This is the biggest success, I think, we have now over 70 individuals that attend our quarterly meetings. Virtually, we have representation from every complex care clinic in the States, a whole lot of HHSC partners, both policy people, quality people, payment, transformation people are involved. A lot of family involvement, including a very active advocacy group called Protect Fragile Kids Texas. All of these individuals and a lot of involvement from the Population Health Department of the University of Texas and Bio Institute. We meet quarterly and update each other and learn from each other. We still, we need some sort of financial support to keep this work going. We need to free up time for those of us who are intimately involved in it. We need support for parent stipends. They're spending enormous amounts of time and we have to make it worthwhile. And we still need more support to optimize our technology platform. Next. Well, this is our team. And one thing I'd say is this is a team that has been working together for pre-pandemic, for almost even before we started the Care Coordination Academy. So there is this incredible alignment of trust and camaraderie. So it is kind of sad, but we hope to continue this work together. So our team will definitely not be disbanding. The team member that is there is Solo, who is our facility dog, who joined us as a puppy in, I don't know, 2019 maybe. And so he's been on our logo and on our communications. I'll stop here.
Thank you very much. So we're going to proceed to a wrap up. Jeff Schiff, you're up first.
I want to thank everyone. You're all leaders. There are children you don't know and families you don't know who are benefiting from your hard work. You've created teams that I hope stay together and keep going long after this Care Coordination Academy goes, because we were just here to support you in your work, and you have shown the ability to make your own decisions, figure out how to move forward and work together. I especially want to say how honored I am to see the dynamic of having families being so vitally at the table to guide this work and set priorities. I said with Meg last week, we had a session that said, if not now, when, if not us, who? And I have a lot of faith that the persistence and the goodwill of everyone who's here will continue. We will see you in some other setting soon. Some of you on the Project Accelerated Academy Health, which is going to be a smaller effort, but we'll keep some of this going. Some, I'm sure, as the new coordinating center efforts come out, but stay in touch. And if we could help you along the way, we'd be honored. And thank you for all the children. It's an honor.
Thanks, Jeff. I thanked everybody at the beginning, so I won't spend any more clock time because I want to give this to Heather Pamela to wrap up. But I just want to point out a few things. One, we've demonstrated what care coordination is, and analogous to politics, all care coordination is local. And I really appreciate how respectfully and organically engagement with patients and families at the local level to inform the process of approach. And then if we collectively can demonstrate the value of what we do, and in particular, measurably achieve equity in every aspect. So think about that blueprint. So we've done a lot to demonstrate feasibility. I think that there are many of the teams are saying, here's what we need to next, and organizations are listening. I will hand it over to Heather now to wrap us up.
Thank you so much, Rich. Well, thank you to all of you so much. The last 2 years have been so much fun getting to know you all. I feel like I have connections in every state now and hope to visit you all someday. Please keep in touch. Please keep up with the work that you're doing. And if we can support you, please reach out. I want to specifically thank our funders at HRSA and MCHB. Rich and Meg, thank you for creating this academy. And this was your thoughts years ago, and to see it play out and how successful it was. Thank you for thinking of me to be the manager of the academy and giving me this opportunity. Jeff, thank you for helping us move all the content along and always joining meetings, even though we were very inconsiderate of mountain time and had you on at 6 a.m. many days and have you on in a different country. So I really appreciate all that you've done for us. Thank you to the BU team, the family partners, parents, patients, all of you that are here today. As always, I have a couple more slides I'm going to run through so fast. Our content will remain open and up on Open Pediatrics. I will share this information in an email later today, but if you already have access to Open Pediatrics, that will not change. Recorded lectures, resources, everything will be up there for you to continue to access. And then lastly, I just want to mention the National Center for Care Coordination Technical Assistance will continue to be an available resource for you post-academy. The information for how to access the National Center is here, and I will share that in my final email as well. Erica has shared the attendance link and the evaluation link. Please complete those. And we are so grateful for this opportunity. We will miss you all. Enjoy the summer. Oh, and that's my son, Thomas. He always makes his way into the presentation. Thank you, everybody.
Thank you, everyone.
Thank you.
Thanks.
Thank you.
Thank you, everybody.
Thank you. Bye-bye.